For the record, my name is Brian Worrell, District 4 City Councilor, and I am the Chair of the Boston City Council Committee on Ways and Means. Today is May 14, 2024. This hearing is being recorded. It is also being live streamed at boston.gov /city-council-TV and broadcast on Xfinity Channel 8, RCN Channel 82, and Files Channel 964. The Council's budget review process will encompass a series of public hearings that begin in April and will run through June. We strongly encourage residents to take a moment to engage in this process by giving testimony for the record. You can do this in several ways. 1, attend one of our hearings and give public testimony. We will take public testimony at the end of each departmental hearing and also at the 2 hearings dedicated to public testimony. The full hearing schedule is on our website at boston.gov /council-budget. Our next scheduled hearing dedicated to public testimony is Tuesday, May 28th at 6 p.m. You can give testimony in person here in the chamber or virtually via Zoom. For in-person testimony, please come to the chamber and sign up on the sheet near the entrance. For virtual testimony, you can sign up using our online form on our Council Budget Review website or by emailing the committee at ccc.wm@boston.gov. When you are called to testify, please state your name and affiliation and residence and limit your comments to a few minutes to ensure that all comments and concerns can be heard. 2, you can email your written testimony to the committee at ccc.wm@boston.gov. Or 3, submit a 2-minute video of your testimony through the form on our website. For more information on the council budget process and how to testify, please visit the City Council Budget website at boston.gov /council-budget. Today's hearing is on dockets number 0670 through 0672. Orders for the FY25 operating budget, including annual appropriations for departmental operations for the school department and for the other post-employment benefits. Docket number 0673 through 0675. Orders for capital fund transfer appropriations. Docket number 0676 through 0678. Orders for the capital budget, including loan orders and lease purchase agreements. These matters are sponsored by Mayor Michelle Wu and referred to the committee on April 10, 2024. The focus of this hearing will be discuss the FY25 budget for the Boston Public Health Commission, including the EMS, recovery services, and homeless services. Today, I'm joined by my colleagues in order of arrival, Councilor Flynn, Councilor Braden, Council President Louis Jen, and the Vice Chair of the committee, Vice Chair Pepin. I would like to now introduce today's panelists testifying on behalf of the administration, Commissioner of the Public Health, Dr. Ojikutu, Director of Administration and Finance, Director Harrington, and Chief of Boston Emergency Medical Services, Chief Hooley. The floor is now yours.
Good afternoon, Chairman Worrell and distinguished members of the Council. Thank you again for the opportunity to testify before you this afternoon. My name, for the record, is Dr. Basola Ojikutu. I'm the Commissioner of Public Health for the City of Boston and the Executive Director of the Boston Public Health Commission. In addition to Tim Harrington, Director of Administration and Finance, I'm joined by Chief James Hooley of Boston EMS. So this afternoon, I'll be focusing in on BPHC recovery services, homeless services, and related initiatives before turning it to Chief Hooley for a presentation on Boston EMS. So I'll start with substance use disorder and the citywide response. Through our Recovery Services Bureau, we promoted a public health informed response to substance use disorder and unsheltered status throughout the city, in close coordination with the coordinated response team, other city departments, providers, and our many partners. Our goal is to provide a full spectrum of recovery services from harm reduction to residential treatment. We are continually adapting to meet the needs of those experiencing substance use disorder, especially those at the intersection of substance use disorder and unsheltered homelessness. In November, with the enforcement of the camping ordinance, the encampment on Atkinson Street was cleared. BPHC played an important role in the weeks leading up to the enforcement, deploying outreach to those living on Atkinson Street, ensuring that we could make sure that we had access to transportation, storage, and shelter for those individuals. This included opening a new temporary low-threshold site that could better meet the needs of some who had been living unsheltered, which is 727 Mass Ave. Post-encampment, we have pivoted to a mobile recovery response outreach team system, seeking out unsheltered residents and others who could benefit from our services. I want to emphasize that low-threshold housing sites, which we spoke about this morning, were vital to the encampment response. We could not and cannot manage the response without access to these nearly 200 beds. And these sites provide far more than just beds. They provide critical support services like medical care, psychiatric and mental health care, substance use disorder care and treatment, and housing navigation services. They help individuals who may have been living unsheltered for a long time, so the chronically unsheltered individuals, make the transition from long-term housing and to treatment. Since January 2022, when this initiative began, more than 600 individuals have been housed at the low-threshold sites, with 200 of those individuals being placed into permanent housing. 167 individuals are currently staying at the sites, and of those, 52 have a housing resource in hand. Our commitment to this model has been validated by a number of studies conducted by medical researchers and academic institutions, as well as ourselves. Boston is leading the way with this approach, and I hope that you will continue to support the increased investment in the FY25 budget to further this work. I'd also like to mention BPHC's work regarding the opioid settlement funds that Boston is receiving. We conducted an extensive and equitable community engagement process over the course of 2023, asking those impacted by overdose to inform us about how the funds should be spent. In response to what the residents shared, we are prioritizing the creation of a family overdose support fund. And in addition, we've established a grant opportunity for community-based organizations who will focus on overdose prevention, naloxone distribution, as well as other supports that are critical to decreasing stigma and increasing access to treatment around the city. We are looking forward to funding this work and working with organizations outside of the Mass and Cass area to expand access to resources throughout the city of Boston. Next slide. So turning to homeless services, as you all know, BPHC operates two of the largest emergency shelters in the region. These are adult emergency shelters. In calendar year 2023, we served over 4,000 people, and we expect the total for FY24 to be even higher. These are shelters for people who truly have nowhere else to go and who we cannot overstate their importance in managing unsheltered status as well as substance use disorder throughout the city. I'd like to encourage any counselor who might be interested to reach out to me if you're interested in visiting either our 112 Southampton Men's Shelter or our Woods Mullen Shelter and to tour the sites. Many of you have already, but certainly if you have not, please reach out. Our homeless services staff are doing incredible work in challenging circumstances, providing not just shelter, but also workforce development, food and nutrition services, and housing services. In fact, in FY24, we've placed 249 individuals from our shelter into permanent housing. This year, we adapted our services to better meet the needs of our shelter guests. Seeing a surge in new immigrant arrivals amongst our guests, we worked to meet their linguistic and cultural needs and established a new partnership with the Mayor's Office of Immigrant Advancement. We also enhanced our harm reduction supports to prevent overdose and expanded access to low-threshold beds within the shelters, creating spaces that are more accessible to those with substance use disorder who might otherwise sleep outside. Again, thank you for the opportunity to speak to you today, and I will turn it to Chief Hooley.
Thank you, Dr. Uchikudu. Good afternoon, councilors and Madam President. My name is Jim Hooley, Chief at Boston EMS, the city's 911 pre-hospital provider, and a bureau of the Boston Public Health Commission. Slide 2. Okay. Although we are a relatively small public safety department in comparison to the police or fire, we are one of the busiest municipal ambulance services in New England, comprised of 428 uniformed members and another 32 non-uniformed personnel. We operate the city's 911 EMS dispatch center, as well as 21 basic life support and 5 advanced life support frontline ambulances during peak day and evening shifts, with fewer during the overnight when call volume reduces, with lowest ebb being between 2 a.m. and 6 a.m., and then we begin ramping up again. Basic life support or BLS ambulances are staffed by 2 EMTs, and as you'll see later, they're far from basic. And our advanced life support or advanced life support ambulances are staffed by 2 paramedics. Our members answered the call for over 138,000 distinct clinical incidents in 2023, resulting in 369 patient transports. This represents a record call volume for us, and it's why the proposed budget includes 12 additional EMTs in the fiscal year 25, which represents a 3% increase in line with the 3% increase in our incidents. Slide 3. Okay, priorities. Our operating budget is shaped by our department priorities, which first and foremost are our personnel, including their safety, well-being, training, and advancement, while balancing the workload through filling vacancies. Through investing in our personnel, we strengthen our ability to serve our community. Next is our patients, who require experienced clinicians providing the most appropriate care with the resources they need. This is also about evolving to meet the needs of our patients and structuring our service model around what is in their best interest. And third is our operations, ensuring systems, infrastructure, and support services are in alignment with our mission. Next week is National EMS Week, and that's also where we'll be conducting our annual department awards and retirement banquet. But prioritizing our personnel is a year-round endeavor. Wages and benefits alone amount to 86% of our budget. In addition to regularly scheduled in-service trainings, we've sent members to an unprecedented number of professional development opportunities, including 15 paramedic scholarships awarded this fiscal year to department EMTs, funded through multiple grants. And with the Mayor's WOO support, we've launched our first cadet program in 2 decades, expanding our options for pathways to employment, and we've increased our hiring of new members by 244%. Comparing this fiscal year to date, July through April, to the same time period last year. And just a quick footnote to that, we had 32 new uniformed hires in FY23, July through April, and 110 new uniform hires in FY24, July through April. I'm also very proud to say that we've reduced the number of uniformed resignations by 54% so far this fiscal year. In attrition is FY24, we had 20 people leave our service, 8 of whom retired, which is a good thing. They achieved retirement age and left, deservedly so. And we had 12 non-uniform retirees, as opposed to last year in fiscal year 23, when we had 36 people who left, 10 of whom were retirees, but 26 were non-retirees. So that's been better than cut in half. Patient care. Through concerted and holistic investment in our personnel, new programs and protocols and equipment, we strive to provide the best possible patient care. Routinely credited with keeping the city's homicide rate low, we pride ourselves with our clinical skill. We were the first in the Commonwealth to be approved for mobile integrated health care emergency department avoidance, and we have launched and expanded upon multiple programs. For patients who are having behavioral health emergencies, our EMT 911 call takers will ask necessary screening questions, and if appropriate, offer to transfer them directly to a licensed behavioral health clinician for telehealth consult. This program, called Telebest, has already benefited 250 patients and is done in partnership with the Boston Medical Center, Boston Emergency Services Team, or BEST, where some of those patients can be serviced directly through them or scheduled for follow-up rather than them having to go to an emergency room. Our other program, the Alternative Response Model, or the ARM, includes an experienced Boston EMS EMT and a best behavioral health clinician who respond to behavioral health emergencies, providing on-scene care, referrals, and if needed, transport to a behavioral health facility or hospital. We've recently expanded to 2 units this past February, and combined, they've cared for over 620 patients. Boston EMS was also the first EMS agency in the Commonwealth to be approved for EMCO CPR. EMCO stands for extracorporeal membrane oxygenation. It's not a procedure that we do, but it's it increases patient survival. It's a procedure that's done in the hospital with the patients being cannulated, but it's done by our personnel recognizing patients who are candidates for this procedure, similar to recognizing somebody having an MI or somebody having a stroke and directing their care and transport to specialized centers where that unique service can be provided. This protocol represents a significant shift in how patients in cardiac arrest are treated and rapid transport to one of 5 EMCO hospitals. The external chest compression devices we invested in last year help crews to provide consistent, safe, high-quality CPR while en route to the hospital. And we've already had at least one life saved using this new protocol, which is all it takes to make anything we do worthwhile. This past year, we also adopted a new treatment protocol for treating diabetic patients, where we've expanded beyond ALS units' ability to administer glucagon. Our basic life support units can also do that. As I say, our BLS EMTs are far ahead of basic, and they set the standard and always have in this Commonwealth, and usually nationally as well. As a department that is inherently nimble and adaptive, we work on a daily basis to ensure our units and resources are deployed in a way to optimize patient care. This includes adding personnel to special events to ensure we are not pulling away from neighborhood coverage, adding ambulances during tunnel closures, such as what we're going to deal with this summer again in East Boston. We closely monitored coverage in East Boston during the closures last year, and we feel that we'll be ready for it again this summer. Next slide. Operations. Supporting our personnel and caring for our patients requires that we have the necessary infrastructure and systems to ensure an efficient and effective operations. This past March, we celebrated the ribbon cutting of our new facility in West Roxbury, which includes a state-of-the-art training center and 2-bay ambulance garage, which is shown in the photo. I didn't have many photos to include here, but we just wanted to highlight that ambulance bay. The city will also begin construction on our new Seaport station this summer, which will be a 2-bay facility located down on Dry Dock Ave. City capital funding has been supportive of a station needs assessment, which was done this past year, and an upcoming study also on locations of facilities in Franklin Park. And just a quick update on the station in West Roxbury. That allowed us to relocate Ambulance 5 from one of the bays, the Faulkner, out into the farther ranges of West Roxbury, and take an Ambulance 17, which primarily covers Rosendale, which up until a few months ago had to change vehicles in the Lower Mills section down off River Street. So again, if you build it, we will come. We will fill it. We'll fill these, and we'll do the same thing, and we'll use that to augment our deployment down in the Seaport once that's up. Excuse me. We've also been working with Harvard University, which is developing a building on the site where we currently lease space in Alston. They expect to build some new facilities there, and they're going to tear down the place where we currently have 2 ambulances. However, during the construction, and prior to that construction, they are going to retrofit a 2-bay facility, which is only about 200 yards away from there that they currently own, so that there'll be no interruption in our ability to cover the Allston-Brighton area. And they will include a brand new 2-bay facility in the building that they're constructing for us. And this is a long-term lease agreement that was helped brokered by the city's, well, the planning department now, formerly the BPDA. We continue to work on addressing station needs in Charlestown, and as well as Allston-Brighton, and looking for other expansions, particularly in Charlestown. There has been a community project going on at Sullivan's Square for many years for redevelopment, and one of the requirements for that site to be developed is for them, the successful bidder has to develop and provide a 2-bay facility there. And they've had a couple of delays in their process, but we've been assured that it still is the #1 priority that the residents of Charlestown want for mitigation for that project. This year, we're also developing deploying a new patient care reporting system, which after review by our personnel had a much preferred end-user reporting functionality. And it's expected to go live by the beginning of FY25. Next slide is the budget. Okay, Boston EMS annual operating budget for FY25 is projected to be $82.2 million, with increases principally associated with contractually negotiated wage adjustments. Approximately 50% of Boston EMS expenses come at no cost to the city through patient transport revenue. The added revenue projected for FY25 is associated with additional transports and improvements in the Medicare and Medicaid payments. Slide 8, okay. Well, thank you. I want to conclude by extending our gratitude to members of Boston EMS who continue to rise to the challenge and meet the needs of the city of Boston and its residents every day. And if I can just tack on, that ability to do that rapid expansion that we've been so far successful with, bringing on those record numbers of uniformed personnel over the last year, certainly it needed the blessings of Mayor Wu and her administration, certainly needed the funding approved by you all here in the council, but could not, and with public health, of course, as well, but could not have been accomplished without the work, the willingness, the assistance from all of the uniformed members, some of the ones you see sitting here today, including some members of the command staff, Superintendent Lee Alexander, Deputy Hamlet, who serves with her as well, who's been a one-man recruiting army, but also Superintendent-in-Chief John Gill, also our union leadership, who's been, as we've converted back to a full-time cadet program, as we've restructured how we've been addressing training offices in the academy, enhancing our EMT program to create more EMTs. They've been very supportive all along the way. So it truly has been a team effort. I wish any of us sitting down on this floor could take credit for the turnaround and hiring and the retention, but it's really yeoman's support from everybody working in the department. Thank you.
Thank you. And Chief Hooley, your department has done amazing work. And just from the 3 years I've been here, it's progressed, whether it's the workforce development, the new initiatives. It's the best in the country, and you guys only are getting better. Want to acknowledge that we've also been joined by Councilor Mejia, Councilor Santana, Councilor Weber, and Councilor Murphy. And we'll start with first rounds of questions from my council colleagues, starting with Council Flynn. Council Flynn, the floor is yours.
Thank you, Mr. Chair. Thank you, Dr. Ojikutu, and thank you, Chief Hooley. Dr. Ojikutu, the public health nurses, one of the lowest paid nurses in the city, they're represented by SEIU 1199. They're seeking a fair contract so that they can support their families. Where are we on that? Certainly, they do a critical role, but they also deserve a fair wage as well.
Thank you, Councilor Flynn. We support public health nurses and believe that they truly are essential to many aspects of the work that we do. Those contract negotiations are ongoing and involve the mayor's office as well as our labor and employee relations. There have been ongoing meetings, so there isn't a lack of communication and discussion. I just think that it's something that needs to be continued to be discussed and worked on.
Thank you, Dr. Ojikutu. Let me ask about Chief Hooley. You mentioned the South Boston waterfront, the EMS station. This is something I've worked on with the residents for almost 7 years now. It's going to play a critical role, significant accomplishment. So let's continue to work together on this. I know we're hiring, Chief, 10 to 12 new EMTs soon. Are we understaffed with the EMTs across the city and paramedics? Do we have enough, or are we understaffed?
We're getting there. Well, we with the number of people that we have currently in training in the academy, by the end of with this budget, we should be able to increase our uniform FTE count to 440. Go up from 428. That doesn't mean I can't promise we won't be back making a documented case for if we need more, because unfortunately the call volume has been going up. It historically used to go up by 1.5% a year. Last couple of years it's been more like 3%. And when you're talking numbers over 100,000, that's the demands on the service are going up.
Are these EMTs, paramedics, like the Boston Police, are they also working double shift, mandatory overtime?
We have, yes, we have provisions for mandatory overtime for our EMTs, supervisors, and the medics, correct.
Is it a major problem like it is on the police department?
It's, anybody who gets mandated, even if it invariably comes at the worst time, right? It's the one time that, I would have volunteered if I could have worked, so I didn't expect to get mandated. So I'll never say it's not a terrible problem. I know I do have one family member who is a member of the police department patrols, and I mean, there were times in the summers where he would be basically, if he was 4 on and 2 off, he would be doubles all 4 days, and sometimes get ordered on days off for special events. Fortunately, the union here was wise in the past, where they put some safeguards in where we have a little bit better structure on limits and on rotations to help to minimize it. But it's still regrettable that we have to count on it.
Thank you. And I know in your opening comments, Chief, you mentioned the partnership you have with the union members. So want to thank you for recognizing them, and thank you for ensuring that we continue the dialogue with the men and women of this great department. Let me ask, Chief, you mentioned the mobile integrated health unit in your opening statement, and call numbers are going up maybe 2% or 3%, which is significant. But through that mobile integrated health unit, are we able to not send an ambulance to a response and send an SUV, send someone else from your team, from the EMS division, that are able to respond to these incidents, but they don't necessarily need to be brought to the hospital. What are your thoughts on that?
Yes, that's correct. There's two parts to it. On the first on the telephone one, on the telebest one, sometimes they can actually, when we put somebody online with a mental health professional from BEST, they can, in some cases, even just make appointments for the persons, or make appointments for somebody from BEST to come out and visit them. So that saves somebody a transport to the hospital. Again, if there's a question of an ingestion or a question of something else or an illness, obviously someone's going to go to the emergency room. But sometimes go in the emergency rooms, which are all, I wouldn't always say bursting at the seams, but sometimes it seems that way. They're always pretty busy all the time now. So sometimes if somebody goes in with a lower acuity behavioral complaint or mental health disorder or needing a refill or something on meds, they could wait a long time waiting to be seen. So the idea is if we can try to get the right patient the right resource, it's better for the patient, and it does spare us from having to use an ambulance for that transport. We had to go through a long process with the state to get permission to do that, to divert somebody from an emergency room, and we were successful with that. But Squad 90, which is the SUV with the clinician, is able to bring people to other spots.
Thank you. My final question before my time runs out. Chief, when we're responding to an incident with a veteran that might be in need of medical assistance, I asked the same question to the police. Do we have any instructions on how to specifically assist that veteran with any specialized care? And if we don't, could we talk about it after the meeting? Because I think it's important that we try to address and support veterans as much as we can.
But no, certainly, thank you, and thank you for raising veterans, especially with Memorial Day approaching. We have, well, first of all, as far as the patient care goes, patients are under state reg and department rule. Patients go to the closest appropriate hospital. However, the West Roxbury VA is specialized for veterans care, and we do get patients. I mean, if you live in Charlestown and you go to the VA, I mean, as long as you're stable, we should honor that, because one, you go there, two, your coverage is through there, and there's people who go to the VA for a lot of, it could be long-standing things from prosthetic care, it could be other things, but there are also so many veterans who may have, suffering from the invisible wounds from war that are followed there as well too. They may not want to open up to you for that, so we recognize that, and we do place a premium on trying to make sure that we take good care of our veterans.
Thank you, Chief. Thank you, Chair.
Thank you. I'd like to acknowledge that Councilor Coletta and Councilor Fernandez-Anderson has joined us. Councilor Braden, the floor is yours.
Thank you, Mr. Chair. Good afternoon again. Chief Hooley, the Alston-Brighton, I'm delighted that we've managed to get a commitment from Harvard to build a new EMS station at that lab building that will be built sometime, whenever. We're very sorry. You and I worked very hard to try and get it on the St. Elizabeth's Institutional Master Plan to get a commitment to a 2-bay ambulance station there, and sadly, due to the demise of Stewart Healthcare, I can't anticipate that happening anytime soon. I think just in terms of capacity, Alston-Brighton is a bit like East Boston. It's sort of on the bookends, and not negating the impact or the importance of the folks in the southern part of the city, but thinking about ambulance service for Alston-Brighton, I'm just wondering, what's the sort of response time for advanced life support to go out to Oak Square? That's the westernmost part of the neighbourhood. Alston Brighton. And I know your schedule changes, your location of your advanced life support ambulances changes depending on shifts and whatever. So what's the sort of worst case scenario and the best case scenario?
Let's see.
If it's not easily available, you can send it to me after the hearing.
Yeah, no, I will. I can do that because I will have to. I would just say that our median, and again, median, that's citywide, right, for priority one has been, in 2023, was going up over the last couple of years. Our target goals had been 8 minutes, and we were up to 7.4, but I assume that with Brighton it was probably a minute or two beyond that at least. So I'll get you the exact numbers for Brighton.
That'd be really helpful.
Yeah.
Because I know long before I ever got into this job, people were asking about the advanced life support service for Alston Brighton, given we have a significant elderly population, and I think given the situation at St. Elizabeth's, like I don't know what's going to happen there, but thinking about response times and getting to an emergency room there's one right there in Brighton Centre, which is great. You pick your patient up, you go to go to St. E's, you get all down, do your paperwork, and then you get back out the door again. But if you have to go the whole way to Longwood or somewhere, it makes the whole thing much more complicated. Thinking about the new location that you're getting, I understand, like in the present location where you have in Alston Brighton, you have a storage space for emergency preparedness and PPE supplies, etc. That was very handy during the pandemic. Mm-hmm. But are you getting any new storage facilities in that neighbourhood in Alston Brighton, or are we able to find alternative places to stockpile emergency supplies for a big emergency?
So far, we have not. We are looking for additional storage space. Yeah, well, like dry, secure warehouse type.
Especially dry.
Not a convex trailer out in the yard, but some place where we can, keep things stored. Because we didn't just have EMS equipment there. There was some of the public health preparedness equipment we had there. Some materials from going back to several initiatives we would keep there. Obviously, if things expired, we would, dispose of that. Yeah. But we would keep things there that would be used for a variety of different potential disasters.
Yeah, I think, going forward, planning for the infrastructure that we need to support your EMS program and thinking about, like, Alston Brighton's it's about 80,000 people right now. It's probably going to be 100,000 in the next 5 years. We have one 2-bay ambulance that doesn't have any advanced life support, and it's been hit and miss. Like, we had a 2-bay with St. Elizabeth's, and now we're getting one at Harvard. But we're being displaced. You're being displaced from your present, and you're losing a lot of capacity to store equipment, etc. And the same thing happened to the hazmat facility for the fire department, because they were in a Harvard-owned location as well. So I really would love to work with you and public facilities to try and have a plan to, see if we can have a predictable path to making sure that we have the facilities that we need, and not just, I think we've been fortunate. Things have fallen out of the sky, so to speak. But it's not very reassuring to think that you think you've got something nailed down, and then the winds have move, and we lose what we thought was a sure thing with St. Elizabeth 2-bay station. So anyway, I think facilities planning and then capital, how a thing proceeds through the capital budget process is very interesting and concerning to me. The other thing, the EMS systems upgrade, money was appropriated in financial year 21, and then it's now, is implementation underway? That's been done in stages. Is that whole process being completed now? Or are you completely finished with that, with your radio system upgrades?
My understanding is we're nearing the end of phase 2, with phase 3 will be the end of it. A lot of it has been, I think the police was a 5-year or so plan, and we were able to kind of jump in after they were moving on for a bit. A lot of the work's already been done up in police headquarters with, I'm not a radio guy, but backhaul and things they call the core, and switching from analogs to like digital, and most of the equipment's been purchased. Like, my understanding is that a lot of that money has been already expended, and a lot of it's encumbered. There's a lot of equipment for the different departments sitting in storage, waiting to be put in. So they are switching a lot of things out as we speak. And some of it is just reconfiguring some of the sites where they were doing everything. We've added many sites throughout the city, but then the older sites, it's replacing power and generators, increasing the air conditioning at the spot. Everything was in need of an overhaul. Yeah,
very good. I appreciate that. It's a big investment. It's $23 million. So. Rolling it out over time, but as long as it's happening on a timely way is more the point of my question.
Yeah, no, it is, and I.
Thank you. My time's up. I think.
Okay.
Thank you, Council President Louis Jen. The floor is yours.
Thank you, Mr. Chair, and thank you actually to Councilor Braden. I had a question about the radio upgrades, and I won't ask that now, but I just want to confirm: is there a date on completion? For the date for completion?
I would have to find that out, because I know we are working along with the police as well, because that's part of the, roughly about 75% of our sites are co-located with them, so there's a lot of the same contractors and management. Everyone's kind of, and everyone's working at the same. Radios are still, we're depending on them now, so you don't take a whole lot of things out of service while you're doing it, so they're coordinating, so I'm not sure where we are on that, but hopefully in another year's time, but I'd have to get a better answer for you.
Okay, thank you. Thank you, Chief Woolley, and thank you for all of the incredible work that you do on behalf of our city and our EMS personnel. I'm really heartened to hear about increased recruitment, which, as you made, it's a team effort, but going to the graduations and the promotions, it's really great to see, and I just want to thank you for that work. Thank you, Dr. Ojikutu, for being here. I have some questions that may not relate directly to what you addressed here, but probably more to the earlier hearing. I filed a hearing on the ending of SOAR, the SOAR program, and I would just have questions about how BPHC plans to address the gaps left by that program, which I think, we've asked questions of BPS to see where they're going to be filling in the gaps because of the, violence prevention work that happens on BPHC. Curious to see what are the interventions and what are the ways you think BPHC needs to step up as a result of the SOAR program, the dismantling of SOAR.
Mm-hmm. So thank you, President Louis-Jean. So violence prevention is a major priority of the Boston Public Health Commission, and we approach it in multiple different ways. Certainly the SOAR program was important. We have other strategies that we are emphasizing and trying to strengthen to ensure that we are both managing violence on a community level as well as managing it when it occurs, and then the healing response, and then engaging people who are at risk of both engaging in violence and being a victim of violence. So I can just review some of that to give you a sense of just the broad breadth, and there may certainly still be gaps, and we're certainly open to discussing and thinking about ways to fill those. So the Neighborhood Trauma Teams Network has been renamed to the Community Healing Response Network, and it's a philosophical change in the name that's changing how we perceive the work from a trauma-oriented lens to more of a healing and strengths-based, building resilience within communities in a secondary prevention sort of way. But the network itself hasn't changed, and there's a broad network of providers. We're trying to strengthen the work that we're doing, trying to make sure that there's fidelity in the response every time something happens, and thinking through how people in the community are made aware of the work that's being done. So they're not questioning where it is, they're not questioning who to call, they actually know. And I think an important part of that is bringing the services that are boots on the ground into BPHC, so it's not going to be contracted out anymore. So we're actually strengthening that program, bringing it into the Boston Public Health Commission so that we can actually know what that response is actually looking like when there is an unfortunate episode of gun violence. So that's one boots on the ground piece of our work that I think is being enhanced. Secondly, I think it's important to mention this idea of capturing individuals, men and women, who are at risk of both engaging in violence and being a victim of violence. We do that for the 17 to 24-year-olds through the Safe and Successful Youth Initiative, or SSYI. And then we also do that through the Men's Health Initiative, which is for individuals over the age of 24. So both of those are case management oriented, one-on-one, individual, really engaging people and understanding what their challenges are and what are the triggers for them to be engaging in violence or for them to be in circumstances where they're victims of violence. Both of those initiatives are oversubscribed right now, so we have more people in them than anticipated, and we're working on trying to make sure that their needs are met and that we have capacity amongst our staff.
Is that a budget question? Is that a budget
well,
issue?
for the Men's Health Initiative, for the Men's Health Initiative, we have 2 positions that are posted. So we're trying to get more people, and I think that's just a matter of finding the right type of skill set amongst people who are, living in Boston and willing to do this work. So we're actively working in these areas, and I think that both of those two, SSYI, which is a state-funded, and Men's Health Initiative, which is, funded through city appropriation, both of those are, I think, successful programs and are doing the work that I think is necessary. In addition to that work, we also have the Violence Intervention and Prevention Initiative, and that one is really focused on neighborhoods, but it's also focused on youth. But it's also boots on the ground because there are meetings, there are people being engaged, they're finding out what people's needs are, meeting those needs, and we're working to strengthen that program also. And that's really thinking both prevention, and then it's also sort of long-term management of communities and building capacity there. So.
Do you work in partnership with the Peace Institute? Is that a service provider? And is that through the violence and prevention?
So that's in the community healing,
the new name
network.
Exactly.
Okay. Yes, the new name, the healing network. Yeah.
Okay. Thank you. I have, I think the work that you're doing, especially the work that you recognize at BPHC, is that it's health and it's housing, and it's the importance of both of those, because people without a place to live and without access to quality health care. You can't really work from there. So I have a question about, ways in which we're helping folks in recovery. Want to shout out to the Phoenix who's here, Sydney and John, and the incredible work that they do. We had our city council first retreat there, so thankful for the work they do. When we're looking at recovery and treatment, the conversation comes up around Long Island. Do you know, can you give us an update? I think the council as a body, if not us individually, supported, more federal funding to get Long Island back up and running. Can you give us a status update on where that project stands?
Absolutely. So basically an appeal with the Massachusetts Department of Environmental Protection giving an approval for the bridge project is ongoing. So that is in progress, and we are, waiting to hear more about that. But while that's happening, we are working with a funded contractor to think about the services, the actual operations, what that will actually look like on the island long term. That has been a pretty extensive engagement, which has involved individual interviews, focus groups, engaging stakeholders across the city, beyond, because it would be not just a city resource, it would be a regional resource. We're hoping that we will have a report from that engagement very soon, and it'll be presented to City Hall and certainly be made available to the city councilors so that you can see what it is that we're thinking for those sort of initial buildings and those initial access to services, after this process is completed.
Thank you. Thank you, Mr. Chair.
Thank you. Vice Chair Peppin, the floor is yours.
Thank you, Chair. And thank you, Chief Hewley and Dr. Ojikutu for being here, and to Mr. Harrington also for the work you all do. I am a big fan of the work that the Boston Public Health Commission does. So again, just grateful to see you here today. Chief Hewley, thank you for the work you do with EMS. It's obviously one of those departments that just on a day-to-day basis, 24/7, do a lot of great work in our city. Do you and your staff feel like you're getting the adequate mental health training when responding to phone calls? The reason why I ask is because yesterday I asked the same question to the BPD, and then this morning I actually ran into a few officers who were asking just for more resources around that field. Do you feel like that's something that EMS is also looking into looking for more investments?
Counselor, are you talking about training more to enhance our skills?
Yes.
And okay,
yes.
Right, okay. I think that is part of one of our initiatives is here. So it wasn't just to have a handful of people either in specialized units. Yes, that's good because they're going to be interacting with the people. However, similar to the police, I would say all of us, all of our EMTs, all of our paramedics, were so many calls involved either some aspect of somebody who may have some sort of either emotional problem going on, some sort of behavioral disorder, or some maybe even have been diagnosed in the past with some sort of psychiatric emergency, but also they're diabetic, or they have a cancer, or they get hit by a car, or you name it, right? So being able to be better prepared and better able to work in those situations would enhance all of our capabilities. And that's one of the things too, like with our the last labor contract we did was geared to like that. Hey, we realize that all of us are going to have to pick up some of these skills. It's not just going to be a specialized type thing, and we are trying to move that way. We were addressing some individual calls, and like I said, a few hundred, maybe about 290 some people that we've transported just since this thing started going. Some of these alternative response models. However, calls for emotionally disturbed person or people exhibiting some sort of behavioral health issue, that's probably over 12,000 calls a year. So that means everybody on every shift is going to have to learn more skills about that. And that is something that, the basic curriculum that's was in EMT training when you learn to become an EMT, or even in your advanced training as a medic. Most of it was more about, de-escalation, maybe restraint, or a few other things. It didn't always give you as much background on that. And that's something that we are aware of, and we are trying to add more curriculum on that.
Thank you for that. And kind of piggybacking on a question from Councilor Flynn. He asked about how are you guys doing on number of staffing. For me, my question is, are you seeing an uptick in applications? Do you think that there's an appetite for people to become EMTs in the future, or is there do you feel worried that you're not seeing that?
Well, we're always, having gone through the last couple of years, we have to be worried about that, even though I was pointing out that we've had some success now in the last 18 plus months. But, again, that took a lot of effort, a lot of bus ads going up and down the street, everything. Because we went from a point where it used to be you posted, hey, we're hiring EMTs, and you waited for the applications to come in, and okay, here's the test, come on in, and we're going to rank you and give you an interview if you did well. To the point where now it's that fell off, but it wasn't just here. It happened regionally. It happened in Boston. It happened with the privates. It happened across the country. I mean, if we talk to people who do what we do across the country, a lot of people were bemoaning the same thing. So we could either just shrug our shoulders and say, well, I don't know, they ain't applying. No one cares. The last 2 years, we've been thinking more and more that, yeah, let's go out and see who we can attract, who we can maybe steal away from somewhere else. But also, what we've been really concentrating on the last 18 months or so is the people who don't even know they want to be an EMT yet. Maybe go out and expose them to some stuff, get involved in some of the schools. I mean, we do have programs, EMT-ready programs in a couple of BPS schools now. We're out at a lot of fairs, trying to do some even just basic CPR, stop the bleed, a few things, trying to attract people in. So they offer scholarships for EMT programs, because sometimes even just to take an EMT class, that's a barrier for some people. Try to come up with different schedulings for it. Bringing that cadet program back full time, where you could teach you to be an EMT, and then after 6 months of if you complete it and you get certified, there's a job at the end. Yeah. Unlike police or fire, where you have to wait 2 years and then apply. That's that's the law for them. They're kind of stuck with that. We were able to come up with this model, and that first cadet class that graduated a couple of months ago is in the recruit class now. So that's good. So but I think we're going to have to really we can't take our foot off that accelerator at all if we're going to compete.
Awesome. Thank you, Chief. Appreciate that. Dr. Ojikutu, good to see you here again. I think you know where I'm going, what my first question is going to be, but Hyde Park Health Center. Mm-hmm. There's a big appetite for that in that neighborhood. I just want to know, what's your take on the need for this? Have you done any studies in the past? Is there room for a study? How can we move forward with this in the future?
So thank you for asking the question, Counselor. So as we talked about before, Hyde Park obviously doesn't have a community health center, a federally qualified community health center, and we have been working with key stakeholders, your office, others, and been in all the listening sessions and the discussions about the issue. I think that one of the things we have to consider is just the needs of the population, and doing a really comprehensive needs assessment to see if that's what is the best next move. There are healthcare providers in the area, and in terms of an actual study, we do have data, the Access to Care Health of Boston report, that should be posted soon. I'm hoping that this will happen before the end of May. In the earlier presentation, I showed a picture where you could actually see Hyde Park, and you could see where the healthcare outpatient providers are there, and then there's no CHC, no community health center. So we do have data showing what's there and what isn't there, and I think utilizing that as in addition to understanding where people feel they have gaps in the healthcare they're receiving is probably the best way to guide our next steps at this point.
That's great. No, I appreciate that. I know that there's a lot of community members and just advocates and members of BPHC in those meetings, so I really do appreciate your commission's just involvement in everything. So thank you so much for that, and we'll definitely continue the conversation.
Great.
Thank you.
Thank you.
Councilman here, the floor is yours.
Thank you, Chair. I'm glad to see you, Chief, here. I'm curious what I've noticed driving through the city of Boston. It seems like there are more ambulances, or maybe I just end up in neighborhoods where I'm chasing the ambulances. I just feel like they're all over the place. But what I have noticed is that because of the traffic, there just seems to be a lot of anxiety when people are trying to get through. So I'm just curious, kind of what conversations have you been having with the Department of Transportation or public, police officers around making it easier for you all to get to where you need to be, because there are people who do not move when you are with the sirens, and sometimes just you're there for, some of your drivers are there for quite a bit of time, and I'm just curious, is it just me that have you noticed it, or am I just paying more attention now that I work for the city that I don't know. There seems to be an uptick on the traffic flow.
Well, first of all, I agree. I see more ambulances out there. I wish it was because we had even more and more ambulances. I think it's just because our personnel are almost constantly on the move. There is unfortunately so many calls, right? And so there aren't too many that are sitting back in the station for very long. You're usually going to one call, and then you're clearing one, or trying to head back, what have you. So it's busy, so that's part of it. Two, compared to during the shutdown of COVID, when there seemed like there was nobody on the street, when every day was like a Sunday commuting, that's not the case anymore. I think, there was always a bit of a degree of, even back in the, quote, good old days, of some people that they seemed oblivious to even if lights and sirens coming up behind them for whatever reason. Maybe they had a good sound system, or maybe they didn't care, I'm not sure. But as far as some of one of the things I've seen on some of the roadways where there's been even some of the different traffic redesigns. One of the good things about the emergency vehicles is if you have we can use bus lanes. We can use other ones. There's no restrictions on us using that. So if we're trying to get calls, that's usually not as much of an issue. If you're just going back and then you're riding like everybody else in traffic, right? I think the other maybe perhaps another observation is maybe just some of the there's a lot of, maybe it's just also a part of the times we live in where everyone wants to, if you want a coffee now, you can call somebody and have an Uber car run up and bring me a cup. But
Right. So those are the
he or she's probably double parked somewhere for that, right?
Yeah.
So that's
So
some of the other things.
the reason why I'm asking that
Yeah.
question in particular as it relates to the response and health is just because I'm just curious, and I don't have a lot of my time, so I'm going to have to come back for another second round. But what I really want to get at as a result of the traffic flow, has there been any casualties that have resulted of the fact that people can't get to where they need to be? And you could just say yes or no.
I can't say at the top of my head.
Okay. So that's something that I'd love to, maybe through the chair, that I'd love to know what, if any, fatalities have occurred because people can't get to where they need to be, or things could have been prevented. I have just seen the uptick, and I'm not sure what is causing it, and I just thought that you might potentially have some insight, but thank you for that. Moving on to, I really am happy to see Phoenix here and all the work. And, we talked about earlier today during the first hearing around kind of I like to see health as a holistic, like a wraparound, right? And housing is part of the conversation. And, spiritual wellness and physical wellness is part of the conversation when we're thinking about health. And I'm just curious, as with the opera funding that is, running out, what do you see as some of the supports or the financial supports that we can anticipate advocating for to support initiatives like the Phoenix?
So I think that, I appreciate Phoenix is also here. I appreciate the work that's being done there. And I think that we've tried to be comprehensive and as holistic as we can based on the funding and the funding lines that we have. A lot of our work is very targeted towards outreach, harm reduction, detox and treatment, and then, transitional housing services. So for both our low threshold and everything else. What I would say is probably the most holistic approach and the most concern for us is our low threshold housing program. That is a critical piece to our work, and I think that it has led a lot of people to gaining access to medical care, gaining access to medication for opioid use disorder, getting the psychological and psychiatric care that they need, as well as being looped into community supports, given the fact that the encampment, that was a community for many people. So then they had to, sort of recreate that within these low threshold housing programs. Right. So I think that's a funding piece that is going to be a long-term issue and ask. For you guys.
I really hate that new clock there. It's really stressful. But I want to get one more question in, and I'm just going to get it in, okay?
You got it. You got 30 seconds.
Jesus, Lord. I want to talk about the Boston Public Health Commission Youth Development Network, which I always do. Every year for the past, 12 years, I've volunteered in some capacity with that particular initiative because they focus specifically on students who are chronically absent. And when we're thinking about violence prevention, what I've learned in that space and working with some of the young people is that oftentimes the reasons why they're not going to school is because of issues of violence. And I'm curious, how are you, what role does the Youth Development Network play within your violence prevention strategy?
So the Youth Development Network, I think, is a great program, as you well know. I think it's doing well. It's healthy. Team is fully staffed. Thank you for the salary increases. I think that morale has been boosted. We're doing evaluations of the work that they're doing, which I think is incredibly important. I think that one of the things that we're going to be doing going forward, and this goes back to Councilor Rorell's question about looking at the Division of Violence Prevention as its own entity, is kind of thinking more about how to integrate a lot of this work. And I think that that's a really critical piece. I mean, we have lots of adolescent programming and we have a lot of prevention programming. Some of it overlaps, but in talking to the team, I think that there are many ways that we could think about integrating them more successfully. So we should talk more about how we
only because one of the young people that I worked with was murdered a few years ago, and he was a participant in one of the programs that I was, volunteering for, and I think that there is a deep connection there, and especially for a lot of the young people who are chronically absent, who are already having experiences at home and at school, that they have to be part of the violence prevention conversation. And I think that had there been more integration there within the violence prevention efforts, the young man would probably still be here.
So I would definitely say that they do violence prevention programming within Youth Development Network and Start Strong and in our Peer Leadership Institute, but what we'd like to do is strengthen that.
That's right. Yeah. That I feel like there needs to be a little bit more of an explicit, like, here's what it looks like. But anyways, I am so sorry that I went over 36 seconds.
You are fine. Councilor Santana, the floor is yours.
Thank you, Mr. Chair, and thank you for the administration for being here. So great to see you all. Chief Hooley, I'll start in your presentation. You mentioned 21 ambulances, right? Is that correct? That you have in the city of
BLS, yes, and then 5.
Okay. In terms of just, are there any that are electrified? Are they electric? Or are they all?
Oh, no electric right now.
Are there any plans for that in the future? Have conversations about that?
We looked we went to one of our last procurements. We looked around to see what was out there. There was one, and actually this is prior to COVID, there was a manufacturer up in Canada, I forget, beginning with a D, that had one, but at the time it wasn't under one of the contracts. We kind of looked at it as a concept. I mean, more than several years ago, we had some electric carts that I think they were a Ford product that we use for special events and small things. They weren't much bigger than golf carts, but it's something that we've looked at, but we haven't seen any really commercially available. I mean, large enough right now to suit our needs. They maybe in special applications, you're looking at them if you're using them inside buildings or in tunnel work or something where they don't want to have fuel or something, but it's, no.
Okay, no, thank you, I appreciate that. In terms of, you all responding to calls, are there any specific neighborhoods? I know traffic has been brought up in terms of one of the barriers to respond to things quicker, right? Have there been any neighborhoods that we are seeing that, it takes longer for us to get there, either because of traffic or because of smaller streets? Or is there data that we can see in terms of like breakdown of neighborhood to neighborhood of response times?
Yeah, we could certainly get that to all these.
Okay.
First breakdown by time of day, any kind of cut. As far as traffic in general, it's hard to say, but on some examples, like you would want to be if a bridge were out, if a tunnel is closed, if or there's something up on 93 with the state police have now shut down the expressway for some reason and everything that backs up. I mean, those events occur as well. Or lately, it seems like once every 2 weeks, oversized truck gets stuck in one of the tunnels or other ones out there, but those do occur. We usually try to rely on getting early heads up from the different transportation departments so that we know about it. Even at the local level and in small communities, the city's pretty good about, they'll put it on the city's CAD system that if N-Star's open in the street for something, or Public Works has to close the street because they're digging, they'll actually broadcast it out. They'll put it out. It'll show up on our CAD because so you know that maybe I don't know, Evans Street in Dorchester is going to be impassable between here and there, and at the micro level, that's even helpful there. Or if a bridge is closed for work in Hyde Park, it's good to know that ahead of time.
Right. No, thank you. I appreciate that. In terms of the Franklin Park study that you mentioned in your opening remarks, can you elaborate on the goals and expected outcomes of the Franklin Park study and how it will impact the budget planning for the area?
Sure. There's money that's in the capital plan that was adopted a couple of years ago. One of them was to do an overall study first on our needs, and I know that we've asked them to look specifically at Charlestown, look at East Boston again, look at Brighton, everywhere really, and we've been party to a couple of different times when it was BPDA, but now planning, when they come in and they do like surveys from different departments trying to find out needs, but also project what you think the needs might be 5 years from now and a little bit farther down the line. And that's for citywide initiatives. Are there places where you can be co-located with another city agency? You get an economy of scale there, or maybe with, in the case of Harvard, they're building something, can you do a partnership? Kind of like a few hospitals we have stations at that we've partnered with them. So to look at all the different options, freestanding versus partnerships. Franklin Park, one, there is some city land up there where Parks Department is. We're not necessarily saying, well, it's got to be that or nothing else, but at all. But a few years ago, I remember the Parks Department and us were both kind of like, hey, you know, Parks was looking at, hey, we'd like to maybe refurbish the area, what they have, you know, where their stables are in there and their greenhouses and stuff. They have garages and stuff. They had a gas pump. They had a few things in there that they said needed some work, and it was like, hey, we should go in together because, you know, it's wouldn't be a bad place. There's room in there, and so part of that was part of that economy of scale, sharing resources that I mentioned. But another part of that is Franklin Park is particularly valuable area for a response to back up so many communities. Currently, even now, our ambulance 12, which changes out of River Street, when it's clear, it goes up and it posts at Franklin Park on the by the Columbia roadside, up by the bus turnaround. That's where we just posted to help back up different parts of Dorchester and even go down to help out in Mattapan. Ambulance, but getting a facility inside the park there where we could put maybe 2 ambulances, that would also help back up Jamaica Plain, Rosendale. We try to put primary units out in neighborhoods, but then we very much rely on zone impact trucks, we call them, who can then be the next truck in, or somebody else who can come over and back up. Because once an ambulance is transporting to a hospital, they're not available until they get back.
No, totally makes sense. No, thank you very much. Appreciate that thoughtful answer. And no, my time is up, so I just want to thank you, Chief Woolley, and your team for the work, all the work that you do, and Dr. Ojukuntu, the work that you all do, and thank you for being here, Director Harrington. Thank you, Mr. Chair.
Thank you. Councilor Weber, the floor is yours.
Thank you, Chair. Dr. Ojukuntu, I had a question for our homeless advocates. What kinds of mental health supports do we provide for our own workers?
Okay. So thank you, Councilor Weber. I think that's an important question. So we do have services that are available for our shelter staff as well as our recovery services staff, because they are very much so aligned and they're dealing with very similar populations. And we recognize that it's a very stressful environment to work in and very taxing work. So we have a contract with a mental health, behavioral health provider. I know that they've had listening sessions, support sessions for our staff, particularly when events occur, but are also available for one-on-one counseling and therapy as needed. So we do have those services. And then we have EAP, which is available to all of our staff members. So with those 2 resources, we've, and I think particularly the contract that we have with behavioral and mental health providers, I think has been something that's newer added because we feel like we need more support for our staff. And I have gotten good feedback about that it's pretty decent.
Yeah, and I guess, do you know how much we budget for that?
I don't, but I can get that information to you in more detail.
Sure. And then I guess I think this morning you mentioned new arrivals, migrants in our shelters.
Yes. Mm-hmm.
That I guess this goes for that group in addition to people who are living there. What is our plan for getting people out of shelters into permanent housing?
Mm-hmm. Well, I think that's the challenge that the state and I guess the country is dealing with, and I don't know that I have a full response per se. However, what we're trying to do is work with individuals on a one-on-one basis in a case management sort of based approach, so we can find out what paperwork they need to get work authorization. That's a big piece of this. And then, of course, trying to move them out of these adult emergency shelters into some more, transitional housing services. We've moved, a number of folks, I don't have the actual percent, from our emergency shelters into other places in the state where they can then access, obviously access work and then engage with the community. But I think one of the major barriers is language, which we're working on and trying to provide services. But again, this is a challenge that I think the state is struggling with and we are struggling with, and certainly, any budgetary, allocations in that regard would be welcome.
It's certainly something I think we all have to grapple with together. But do you have data on what the average stay in our emergency shelters are?
Okay, so that's a good question. Yeah. I have the data in regards to the number of people. I don't have the data on the average stay. Let me see. No, I'll have to get that to you. I'm just looking at what I have on me. Mm-hmm.
Okay, yeah, thanks. I anecdotally have heard stories of people spending years, in emergency shelters. I think that speaks to the need for, getting people on their feet and out of the shelters and in a permanent place where they can keep their kids in the same school and work in a place and not lose that connection. And I just thank you, Chief Hooley. I just first congratulations on the new EMS facility on Rivermore Street in West Roxbury. And I think we talked a little bit about response times. I read last year, and I think you just mentioned it's 7.4 minutes is the average response time in a health emergency. Is
for priority one, yeah, which is beyond our goal is 6.
Yeah, and so what do we need to get to 6? What is, how can we help you?
Okay. Well, we've been adding personnel so we can add more units as well on the street. Currently, a lot of the people that we've added that I mentioned are still in the pipeline. They're currently in the academy. They're recruits now, 30 some odd, and then cadets, I think it was 13, 14, I forget how many. But anyway, so who are currently in training. So they haven't cleared yet. Plus, we're already recruiting for our next class, which probably will be starting in October, with the idea of us trying to get to that 440 mark so we can deploy additional units. So that'll be an important first step. Also, again, we also look at how we, prioritization, because again, it's the priority one calls, the ones that are a bit more sensitive to that time frame we're trying to get, where some of the lower priority calls, honestly, some of those are the ones where they could be disposition, they could be other issues, they could be somebody who's would be better served if we could expand some of the services where people are going to a clinic, or people are able to go in for some other service which is more related to what their problem is. Because if not, what happens then is 911, and then the hospital, the emergency room sometimes kind of become the safety net for a lot of different things, Well,
so, and I know Councilor Santana asked about sort of more neighborhood by neighborhood response times.
Yeah.
Do you think that those response times are going to be the same neighborhood to neighborhood, or they're going to show a disparity between the response times based on where you live?
I would say, typically there could be some changes if you went by neighborhood. I mean, if you went back several years ago, like some of our better response times would be, even though the call volume, there was more calls than volume in, say, Roxbury, South End, parts of Dorchester, Jamaica Plain, we had a denser population, more people living there. However, we had resources plus the hospitals between the Longwood area hospitals, BMC. You had ambulances coming and going out of there. So you could have the closest ambulance may be somebody who's just leaving BMC, even though they're going back somewhere else. So you had the ability to redirect that truck to a high priority call. So it's so again, we want to make sure that on the outlying districts, like Council was asking about Oak Square or in Heights in East Boston, where now you get that second call in, or maybe a third call in for outlying areas, or the farthest end of Hyde Park, you want to make sure that you have a resource available. That's why if we get the idea that we can staff extra units and try to be able to move our trucks and have that we call the, for lack of a better term, zone impact trucks, place ambulances that we can move around to help shift to cover areas where we see we're getting light. That's one of the strategies that served us a lot, served us well in the past, and we're trying to emulate that.
Okay, thank you. I think that's my time. Thank you, Chair.
Thank you. Councilor Murphy, the floor is yours.
Thank you, Chair. Thank you, Chief Hooley, for being here and for still being here, Dr. Ojukuto. So I do just want to uplift, I think many of us already said it, but earlier when I asked the question about this shift in needs with COVID-19 and the tent encampment down, and you did say that recovery services and those needs are at the top. So I do also want to shout out the Phoenix and our partnerships. We know that the crucial work that you do in the public health field can't happen. We won't have a healthy city without those partnerships. So they're one of many, but they're here. So just wanted to also uplift in that need that recovery services are always probably going to stay at the top of your need because it affects so many other parts of a person's life if they're struggling with that. Like earlier, I'm just going to read through a few, and if the time allows, we'll get to them. So hearing from some of your members, the expanding the mobile integrated health program, which I believe targets low acuity emergency calls and can divert them from the emergency departments. The hope also that this will expand their ability to respond to overall calls across the city. And if you could touch on also the single responder units that could allow us to decrease our carbon footprint. You talked about the traffic. I know Councilor Mejia brought up, I see it also. I think we all see it when we're driving around, and it does seem as though our ambulances are stuck, and seconds stress me out. So knowing that they're trying to get through. You mentioned your ability to drive in the bus lane, but if you could speak to the bike lanes, because they are different, and you don't fit in a bike lane, and is that causing more of a traffic response time? Also, how can we ensure that we bolster our mental health responses? And I know last time you were here, it may have been budget, may have been a hearing after, but talking about the resources to divert people to then be placed in a direct mental health bed. So if we're continuing, I know you talked about a special line when you call 911 and that support, if you could update on how that is doing. Also, I know Councilor Coletta and Braden and I worked hopefully have a hearing soon on the EMS service zone plan, and as we work with the planning department, and we did talk about some of the new ambulance bays that are opening up across the city, but making sure that we are responding to the needs as we grow in different parts of the neighborhood with our population and our needs there. And if you can talk about the strain it puts on the system. Another thing I hear a lot about is the 911 calls, that they have to respond to private healthcare, nursing homes and hospitals, and then you unfortunately sometimes see that there isn't an ambulance in a certain zone that's available if there is a call to come in, and oftentimes it's because they may have had to respond to a private hospital, rehab or nursing home. So if we can get to some or all of those, that'd be great.
Okay, thank you. Okay, yeah, expanding MIH, I think, one, that is a good idea. Two, I think we completed our report to the state because we had to reapply for it every year before we did. We have to show the numbers, share the data, and I think it is showing itself value, not just for us clearing up units that are available, but also for the patients. I think we have enough people who are interested in doing it. I think that if we had more facilities where we could potentially bring people to divert them from emergency rooms, that would make it a little bit more successful. It'd be nice if insurers or CMS or somebody else would see fit to reimburse it for payments. They don't currently. They only cover transport to our hospitals. However, that still wouldn't stop us from wanting to provide that service because we think it's the right thing to do, and we think it's for the patient and it's cheaper for the system in the end, right? We also, because we did for a while, we were even with Squad 80, which was another non-transport. They weren't transporting, but they could help divert to recovery teams to get people to the round, also some other programs. We have the ability under our MIH to bring people to some care directly for addictions, but you need those facilities identified and set up as well too. So the opportunities are still there. Bolstering the mental health process. I know we do have. I mean, the states I think has some kind of a call line. I think there's more. I don't know if it's more for suicide prevention. I'm not sure, geared, but which is good. But if someone calls 911 still here in Boston, we do have the ability to also transfer them to people who are under agreement with us, and that we have permission from the state to transfer them to. Because normally you can't. Once you take a 911 call, you're not supposed to transfer it. But we do have the ability to do that and try to get people the services. The planning for the expansion, that's very important, because if we want to see where we're going to be 5 years from now, we have to start planning for it now. As you were saying on the public facilities development, those things take a few years from, even when you have people who want to support you, first you have to come up with a program, study, a need, then you need a site, and then you need development and a plan, and then a budget, then execute it, which is where we're just about at now for the Seaport one. The Academy re-update was several years ago. On the Seaport, that goes back to 2004, I think. But in the last 2 years, it grew legs. Yep. Thank you, everybody. Charlestown, when we had that meeting with the city on that, I asked for, we were hoping we're still going to get 2 bays at Sullivan Square. I've been asking for 3rd bay, because I really do think we need something closer to the north end, North Station end, because that's just become so congested down there. But still in Charlestown, maybe down by the Navy Yard. Calls to privates. We've been, not calls to privates, calls to other facilities because of lack of privates for, again, we've always said, hey, if you've got somebody who's, acute, really, really sick, you got to call us first. But a lot of some facilities, sometimes it's because they can't get a contact provider for somebody who's maybe not scheduled, but maybe it's getting near the end of the day, but then they're going to be, somebody shows up when they get ready to close, or somebody who they just want to send off for a test or blood work that they can't do there. We really do try to impress upon them that they should always try to make that call first, because that's one of the things we can do to try to help with the response time. That one of the things we can do to help to address that Councilor Weber was asking is some of those calls could potentially be even dropped down into a lower acuity. And I don't mean that they're less sick, but if you have that same patient who lives, who's in a health center, say, I don't know, in East Boston or South Boston, but her twin sisters in a single-family apartment across the street from it, and they both call at the same time with the same complaint. We should be going to the home first, because they don't have doctors, nurses, anybody else around them. And that's, we try to explain that when we speak to people, so that we have to prioritize that patient first. And then, and we have to move them down in the queue. And I think that's trying to be responsible, not because we're trying to be negative or impact anything there, but it's triage. If we have to. Now, unless we have unlimited resources, that's going to be difficult not to do, but we have to have those kind of conversations with those facilities, and one, to hopefully try to get them to make that the people that they contract with maybe a little bit more accountable.
Thank you.
Thank you.
Chair.
Councilor Coletta, the floor is yours.
Thank you, Chair, and thank you both. Thank you all three of you for being here. I apologize that I was late, but I was listening in, so I caught some of the presentation. I was honored to have the opportunity to ride along with Nick Mutter, who was here. Hello, and a couple of other folks on one of the ALS paramedic trucks. And we rode about for about 4 hours. We went from South Boston to East Boston to Charlestown to downtown, and it just was so eye-opening. And I have said it a million times, but the dignity that they showed those folks and the professionalism was just incredible. So I just want to say thank you, and thank you to all the EMS folks out there. I know that we've seen an increase in call volume again this year, especially in East Boston, I think in Charlestown. I don't have the exact data on that. Charlestown, we've mentioned it a bunch of times, but based on the new zoning, which is encouraging growth in that particular community, and based on the population projections, we're going to need that second or third ambulance bay in Charlestown, and that's something that you and I have talked about quite a bit. Chief Jameson was in here last week for our planning department budget hearing, yep. And he had promised that East Boston would get a public safety specific neighborhood needs analysis, which was really the crown jewel of Plan Charlestown, where it talked about everything from water and sewer to public safety response in conjunction with population growth. And I think that that's something that needs to happen citywide. My understanding is that the planning department and Alston Brighton might be getting one, but I'm wondering, like, holistically and zooming out for the whole entire city, have you been in discussions with either the Planning Advisory Council, or the planning department, or anybody in the mayor's office to think holistically about planning out 20 years from now due to the projected population increase, and while we try to meet our Imagine Boston 2030 goals?
Not a specific 20-year out citywide, but when the invites or they may call them invitations, I call Means, you better be here, come out. For example, when they did the ones for Charlestown, and I think that was back when it was still under, what do you call it,
BPDA?
Yes, thank you. I remember it was a coffee hour in Roxbury when that was going on. It was like, run to the car, get on that for 90 minutes or so, and it was to try to address some of those needs. What do we think we need, and what do you think project what? They were going on everything from like schools. What are they going to need for school age kids? Obviously, I was more focused on EMS, but that's when I referenced that conversation on that. What we thought we needed in Charlestown was probably even another facility besides the much spoken of Sullivan Square project. We needed something closer down the other end. There was been invited to some conversations on Brighton as well, but it's been sort of more neighborhood by neighborhood. So I don't know if that's the approach they're taking, but I haven't seen a citywide convert. I welcome it, but I would have to make an inquiry.
Okay, I do think that Plan East Boston and Plan Charlestown was neighborhood specific, and we're going through squares and streets and all of that, and I think that approach from neighborhood specific to citywide is a welcomed approach in trying to plan for our city's future, especially as it relates to public safety. I do think that that's more of a capital plan call out, and so I would love to have you supported even more so in the capital budget in the coming years and baking in a plan 5 years, 10 years out for EMS in particular. And I've been stacking up EMS as it relates to other public safety departments, so like fire and police. I actually tried to go in through the open data set and figure out what the average salaries are. But my understanding is that because it's a political subdivision of the Boston Public Health Commission, you all don't publish your average salary data. Is that correct?
I'm sure
It's not public record?
No,
It is,
I'm sure
it's a public record.
It's probably just
like
in
anything
a
else.
different.
Okay, it's not in the open data
Yes.
set, so I would love to get that information if possible through the chair, just the salaries for all of our EMS folks. Last budget hearing in the fire department, I asked about average times and responding to medical emergencies versus fires and time spent in the firehouse. Because I had gone on that ride along, it really opened up my eyes to just how much EMS does. And when we're on scene, the fire department was there first, and then they would leave and go back. And it really seems like they're filling in the initial moments because EMS is trying to get there, because we simply just don't have enough ambulance space or trucks. And so it's lopsided. And so my goal is to right-size that, not only just in ambulance space, but in salaries too. Because and we talk about this often, the staff members are not meeting a wage that they deserve. And that's true for all departments, but some of these instances and some of these incidents that they go out to is just so difficult, and they really should be getting paid more. So I'm interested to get that salary data. Thank you so much. I would love to talk about the mobile integrated health programs too, and just understanding what we're doing to expand that. It's a win-win. So to Councilor Santana's point earlier, it's an opportunity to decrease our carbon footprint, but also has the potential to expand the ability of paramedics to respond to overall calls, since they can be single responder units. So just wondering generally how that's going and if we've expanded the mobile integrated health programs.
Well, I think February is we added I think it was February, we added the second unit to the squad 90 for the psychiatric, not psychiatric, but more for the psych support, the emotional support, behavioral health unit. That's two that are operating on days for 10 hours. It would make sense to expand it then to another shift, add it on to evenings as well, and again, be able to hopefully be able to expand it so that we have it on, excuse me, available through just more hours of the day. I'm not even sure what the on the police departments, the units that have the best team with them. I'm not sure how many hours a day they were able to expand. I know they have them on days and evenings. So some of the limiting factors there, it took a bit to attract and hire the clinicians that we're partnered with, but it's not impossible. I mean, we did finally get several good ones to interview, and we were able to get the second one to add that unit there. But it is something that is, I think, the data is showing the value. It's certainly showing that demand is there, and that the work is being done, and that we should endeavor to expand it. On weekdays in the school year, we get as many calls to, believe it or not, school-age children. It's not all adults who have depression or some other mental health, behavioral health disorder. It's really a pretty full, it's a wide gamut of patients that we encounter. I know one day, like I think the unit, they did 2 or 3 of their calls, they were like to the Italian home and 2 other schools, where normally when you go there, if it's a kid, you send an ambulance, school nurses requesting, what have you. Kids can't refuse, and unless the parents are there to say, no, they can't go, or we don't want them to go, we pretty much wind up taking them to the hospital. But by having Squad 90 available one particular day, 3 of those were able to be resolved there. 2 of them, I think, agreeing to go to a site somewhere else, where the parent was actually great. The parent preferred that, but the ambulance really can't do that right now. That unit could do it, but again, if we keep establishing protocols, then we can expand on that. We really should take advantage of this while we have it now to try to expand it out and make it more of just a routine care.
Thank you. Really quick, I am interested in expanding that, understanding exactly how much it costs to operate one of those. So next round, maybe we can talk about that. And then next round, just as a heads up, I'm going to ask about the Sumner Tunnel closure and then emergency response for homeless folks due to a fire. So just as a heads up. So hopefully there'll be a second round.
Yep, there'll be a second round.
Thank you.
Councilor Fernandez-Anderson, the floor is yours.
Thank you, Mr. Chair. I'm going to try to read up my questions in advance and then remind you of what I said if if you forget. Commissioner Hooley, Chief, I hadn't seen you earlier. Nice to see you here. So these questions really aim to delve into collaborative efforts between Boston Public Health Commission and the Mayor's Office of Equity and Community Engagement. As I'm looking through your budget and looking on in terms of where the emphasis is, the focus is a lot on opioid or addiction services, a lot on child development or services, a lot on COVID. What else did I see? And some interventions and preventative services, but a whole lot is on addiction and mental health. So I wanted to, and I think that because of what the community or advocates or folks, lobbyists are lobbying for, and then we get policies, and then we get issues. So sometimes we're often reactionary, or we have to respond to a thing, and then we have to sustain those services, right? We have to continue to invest in what's already in existence. And as I'm thinking about structurally, programmatically, how we can begin to work on this systemic racism issues, from the Health of Boston to Boston Foundation to Embrace, I've read all of the reports, and piecing them together, it's really heartbreaking that we continue to have to respond to a thing like COVID, and then Black people have to die the most or suffer the most because of already pre-existing situations or illnesses. And so addressing social determinants of health and systemic racism, the city is responsible for specific initiatives or programs aimed at addressing housing stability, economic inequality, food insecurity, other social determinants of health, and disproportionately impacts Black residents. And so given the alarming disparity highlighted in the Health of Boston and other reports that I've mentioned, I guess, what concrete steps can we talk about that is being taken to address these social determinants of health, to dismantle systemic racism practices and structures that contribute to those premature death of Black residents. And then, I just want to touch on 5 things, and I was taking notes, and I basically pieced it into 5 areas, and I think, or sectors. I think data sharing and analysis, community engagement and input, policy development and implementation, program planning and resource allocation, monitoring and evaluation with benchmarks, perhaps an online dashboard, and council oversight. The way that I see it, and just to narrow this down, is that the Office of Equity has a responsibility or we have a responsibility to eventually codify this office to implement certain programmatic things that either are preventative in a real way, or that they invest in social determinants of health in a real way, but that we are measuring tangible action plans or these benchmarks or metrics, and then we are transparent about it by creating this dashboard that we're communicating with the public in terms of our progress. And so looking at all of this, I have, questions, of course, based on all of those sectors, and one of them, in terms of data sharing and analysis, if Boston Public Health Commission is working with equity, that means that Boston Public Health is informing Equity Cabinet in terms of the data, and the Equity Cabinet then is providing analysis and an analytical approach to critically create these plans based on the need, based on the numbers. And then community engagement, of course, and input is crucial, because then you are creating sort of, these platforms where you're doing listening sessions or forums and surveys, and you're gathering information from stakeholders, and to be able to balance that or to better inform what you already know in numbers. And then in terms of policy development implementation, obviously, hopefully that leads to where we step in or where we collaborate to basically inform evidence-based policies to address these needs. But then I think the programmatic planning and resource allocation is happening already, right? There are two levels of addressing this, and Dr. Jakutu, I really feel like I'm preaching to the choir because I think you're phenomenal and you're already doing this. But I think, if anything, you need more money, not less money, but with proper plans in place. You wouldn't be able to say, Boston Public Health Commission is the one responsible, or the place responsible to dismantling systemic racism, but it's a collaborational partnership with the Equity Cabinet to do that data analysis, to inform these numbers or these policies, to be able to create these allocations based on a plan. And so where are we with collaborations? Where are we with these types of analysis in terms of data collection and obviously reports that you have? Where are we with developing a plan, again, based on evidence-based policies? And where are we with partnering with community engagement or Office of Neighborhood Services so that we can create that community engagement component? And then finally, the metrics, right? Creating those benchmarks and monitoring this plan, this tangible thing that we can say we've met this benchmark, or we're here, or we're there, and we're actually pulling people out of poverty. And this is all understanding that there are already third-party companies that can be commissioned to come in and implement such metrics. And again, I don't think it lives solely in Boston Public Health Commission, but I think you are at the base of this partnership. And I just wanted to hear your feedback or work or updates on all things across the board that I've mentioned.
So thank you, Councilor Fernandez-Anderson. So first, I would say that a lot of the work that you all hear about and that ends up being in the media is focused in on substance use disorder and unsheltered status, and of course COVID and other respiratory illnesses, because those are sort of the issues of the day, if you will. I think it's unfortunate only because we are doing so much in so many other areas that I think is noteworthy. The data that we collected with the Health of Boston is secondary data, meaning it's coming from other data sources. But I think what we did this particular last year was instrumental, particularly as it relates to mortality, premature mortality, and life expectancy, in that we were able to zoom into the census tract level to really understand the differences between populations and micro communities around the city. And it's clear that we have significant gaps in life expectancy, significant challenges that are facing our city at the community level that we need to address. So we didn't stop there, though we publicized that data and put out a report, and we're still evaluating to get more detailed information to fully understand exactly what's happening within our communities, particularly as it relates to chronic diseases. We didn't stop there. We for the last year or so, we've been building a partnership with a number of entities that I think is novel, and we will be announcing something soon that will focus in on what we're sort of looking at as healthy longevity. So what do we do as a city to close the gap that is evident by race and ethnicity, but then also to think, how do all of us just live healthier, longer lives here throughout our city? And so that's a partnership certainly with departments. So the mayor's office, the Office of Equity, and that team is certainly aware of and is, supporting that effort in being involved in discussions. But it's also with the Boston Community Health Collaborative, which is the CHNA CHIP, so it's the Community Health Needs Assessment, Community Health Improvement Plan. These are stakeholders, community-based organizations.
The Boston Community Health.
The Boston Community Health Collaborative. So that's our healthcare institutions, the hospitals, the community health centers, community-based organizations, residents, the development corps, lots of different stakeholders across the city that come together to talk about what are the health needs, what is it we're doing, what are the different areas that we're most concerned about. So the areas that they identified were economic mobility, housing, access to services, and mental health. And in each one of those, we have representatives from Boston Public Health Commission who are participating in that process. But to drill down even further within this we're calling it right now Roadmap for Healthy Longevity. The name actually may change by the time it's actually released. To drill down even further, we're specifically looking at the disease entities that we know are causing the premature mortality. So cardiovascular disease and cardiometabolic disease, that includes diabetes and heart disease. We're looking at preventable cancers. So all the cancers I talked about colon cancer, but certainly prostate cancer, breast cancer, all of those. We're looking at substance use disorder. And again, we have to look at substance use disorder because that is causing death within some of our communities that have been made most vulnerable. And we're looking at Black morbidity, mortality, and infant mortality. So all of these pieces, we have strategies that are being discussed with the mayor's office across departments of how we're addressing them. And most of them have some sort of funding behind them, but some of them don't. And a lot of this is about some of the upstream drivers. So certainly we're talking about we're certainly talking about like food as medicine and, access to healthier foods within our neighborhoods, but then also, exercise and nutrition, sort of downstream type individual interventions, but kind of going just across the spectrum and figuring out what it is that we need to do differently within our communities. So we will present that in the next, I would hope, the next month and a half or so. We're looking sort of at July to talk about that because it is an important partnership that does address many of the issues that you've described in terms of structural racism, systemic inequities, and the kinds of things that we as a public health department can do in partnership with many different entities across the city. So I think that's something that I think is important for us to talk about in terms of inequity. In terms of other work that we're doing, like other partnerships, we are looking for more non-traditional partners, and we're talking to entities that hopefully will serve as funders, for some of this work. And I think that's has been the challenge, but it's certainly the work that all of us are trying to do so that we can do some things that are more novel and visionary in regards to how we manage these issues going forward. Because I don't think that the public sector can do it on its own, and it can't do it on its own even with hospital partners, which is what we've been doing and is more sort of our traditional approach. So we are sort of looking outside of that to figure out how best to address these issues in a robust and comprehensive way.
Thank you.
I was over. I'm sorry, I was talking.
Oh, no. Were you done with your answer?
No, I'm done.
Okay.
I wasn't paying attention to the,
I had a closing comment, if that's okay with you.
A comment? I'll allow you a comment.
Thank you, Mr. Chair. If you notice, everyone else does this, but I ask permission. I ask permission. Yes, what you guys do is you don't ask permission, you just talk over the clock. May I?
Go ahead.
Thank you. So I thank you so much for that, because it does give it gives me a clearer picture of all of this incredible work, right, that you have to do. It doesn't speak to specifically the campaigning or this undertaking of the partnership between Equity Cabinet and as in the city. It speaks to your work and how hard you work and how much you work in the Boston Public Health Commission and community partners and stakeholders, but in terms of the equity cabinet and looking at specifically how to dismantle these structures in terms of informing allocations and, for example, the bank could be participatory budgeting, right? Where policies would actually inform why they would need the money, and then it would be less of just, throwing the slush fund somewhere. It would be more of, this is the pot where the money goes after we've already done all of this work with these benchmarks, understanding that these policies have informed us that we need in the next year 5 million, in the next 5 years 10 million, the next whatever, and increasing it, but actually saying these are the areas or domains where these investments need to go. And I think that would be a more comprehensive and more practical approach, not on, of course, I'm saying this is not your part, a more practical approach of informing participatory budget allocations.
Thank you, Councilor Anderson.
Thank you.
And to my colleagues, we stayed here until 7 o'clock last night, but we'll have another round of questions, all right? Not saying we'll stay here until 7 o'clock today. I wanted to talk about ARPA. We have $30 million that is encumbered but unspent. There's more than $2 million remaining out of the $2.9 million for total for wastewater for COVID-19 tracking. More than $6 million encumbered for Center for Behavioral Health and Wellness, and then more than $4 million remaining out of the 11 for COVID-19 vaccinations. Are we looking for other places to allocate, that ARPA money? Are we on time? I know some of this is based on COVID. Are we still engaged in some of that work?
So can I just make a comment programmatically, and then I'll turn it to Tim to talk about the budget. The dollars that have been allocated to COVID-19, I think, one, well spent. Two, we're still utilizing those funds in many ways. Specifically, just give you an example, the wastewater money. So certainly, I think we're obviously at a different phase of that, pandemic, and certainly concerns rising that would make people look at the wastewater data on a regular basis for COVID-19 have abated, right? But we are also looking at influenza, so influenza A, B, and then RSV. Now, I'm mentioning this because we basically set up a system that built infrastructure for the city that will help us as we start to look at these new pathogens that you may have heard about, H5N1. These are subtypes of influenza A that we are now discussing with the Broad, discussing with BioBot to figure out, well, how can we make sure that we as a city know when there is an infection here, and then how are we going to intervene? So we set up something using COVID dollars that we would like to keep going so that we're able to prepare our city where other cities have not done this. So I really think it's a really important investment, and I do think that the vaccination money is also an investment because we are going to we're going to come back around to sort of the seasonality issue where kids are going to need to go back to school, and we're going to need to have some vaccination events. So we're utilizing those dollars for that issue, and then it's not clear right now with these new subvariants. We just don't know what will happen. So we're just trying to make sure that we have some money in the bank so that when it's time to vaccinate, we can put forth that effort, whether it be through mobile vaccination or vaccination clinics or whatever. So Tim, do you want to?
Yeah, and I could just add, for the COVID-19 vaccination line, what we did is we shut down kind of all the clinics that we were running sort of at the end of the springtime to make sure that we saved enough of those funds for the next, flu and COVID season. So we've got around $3 million there. And then as far as the other lines go, if you look down at the substance use response, most of those dollars are essentially sort of obligated. And I think I talked a little bit about that already today. And then for the mental health lines, same thing. Most of those, it may not be showing up in the the numbers that you have, and I can kind of make sure that you have the most updated numbers. But most of those dollars are all obligated for over the next several years through a number of different contracts. I don't know if you want to add in anything about mental health, behavioral health, but I can say that almost all of those dollars are all essentially obligated over the next several years. Yeah.
All right.
Yeah. What we did last year, Councilor, is that we did have a number of mass and cash requests for new investments. And the city kind of came back to us and asked if we could reallocate a lot of our opera funding. So we did that last year. This year, we just don't really have that flexibility, you know, in the funding that we have, the funding levels that we have right now.
All right, thanks. And then what are the 8 BPS high schools with school-based health centers? What types of use and benefits are we seeing from them? And is there a discussion directly with BPS to have in part of the new hub schools? And do we also have school nurses at the schools with these services?
So that's a good question. I have a partial list here, and I'd prefer to give you the full list of the 8. You know, it's BLA, it's Brighton, it's Madison Park, it's Burke, it's BCLA. I can give you the full list. And in terms of the services that are there, it actually differs, so that's a good question. Some of them are more comprehensive in terms of the services that are provided. Some are just mental health services that are provided. It really is based on what other services are already available at the school. We are trying to fill in gaps. So that's what's going on. But we can certainly send you that comprehensive list with details at each one after this. Perfect.
And just wanted to make sure on the job vacancies at BPHC right now, I have, my math is mathing, around 200.
I think the number that I saw that we submitted was 153.
153? Yeah. Okay. All right. And then Chief Hooley, thank you for all your work. I see that we budgeted less for overtime this year. Is that because of the new academy class? We're hoping that that will help decrease overtime?
That would be a hope, yes, because, but no, I shouldn't say it like that, but in years past, if you're down 40 positions, the only way you could make that up is by reliance on more and more overtime, whether it's, in most cases, it's, people voluntarily accepting it. However, it's, if you're staffing, you spend more money there because you have to, if you're not filling on straight time, you are more reliant on the overtime. That's correct.
And I want to make sure that we're constantly advocating for EMS. So just from my understanding, every 100,000 or every 10,000, how many EMS personnel do we need out on the road?
Well, looking at what was allocated in the, let me see, for the 12, I got it here somewhere. For the
I just want to ask one last question.
For the 12 positions here, I think it was, was it 1 point? I'm sorry. No, I'm looking at capital.
And my last question, Chief Hooley, is are we tracking response times by priority calls? So do we know how fast we're getting to priority 1 calls?
Yeah, we break them down by priority 1, 2, and 3.
Okay.
We do do that.
What's the response time to priority 1?
Okay, priority 1. The last time we checked, the median response time was 1 point. I'm sorry, 1 second. 7.4. I spoke to that earlier. Priority 2 was 10.4, and then priority 3 was 10.6. But there's much less of those.
Thanks. Yeah, I thought the 7.4 was the median for response time in general. Thank you. Thank you, Chief.
Yep.
Now we'll go to public testimony. When your name is called, please come down to one of the 2 podiums and state your name, neighborhood, and/or organization affiliation. Please speak into the microphone, and please keep your comments to 2 minutes. Sydney, the floor is yours.
Councilor Worrell, Chair, I actually, for the 12 additional EMTs, says the city's total appropriation investment is $1,300,000.
1 million, okay.
Because again, remember,
Right, and
approximately 50% of our budget comes from what we were able to generate here.
And what's the size of the total staff?
Size of the total staff?
For EMS, for EMS.
Oh, currently it's at a uniform, it's
Yeah.
back to page one, I think it's 428 uniform, but we're going to be going to 440
Okay,
with adoption of this budget.
all right. Thank you. Sydney, the floor is yours.
Hello. Good afternoon, everyone, and thank you for being here and supporting all this work and listening. My name is Sydney Durand. I'm a resident of Boston, and I'm a staff member at the Phoenix. I'm here today mostly just to share about the impact of our programs and advocate for continued funding from the city on holistic and innovative recovery and mental health support programs. I think we're really a leader in this area and just want to continue to partner to do this work. We as a city and the Phoenix. The Phoenix is a nonprofit, for those of you who don't know, who help anyone impacted by substance use disorder to find a supportive community. And the main way we do that is by offering free sober activities that range from coffee socials to fitness events that are open to anyone with at least 48 hours of continuous sobriety. And that sobriety is defined by the individuals themselves because we're open to all pathways to recovery. We operate a 10,000 square foot free community space that's in New Market Square, and it's open every day and offers 80 free activities each week. We host activities that are also embedded throughout the city. This includes museum tours, nature hikes, and finally, we also offer on-demand and programs digitally so folks can access programming via our app in a safe community that way. Every activity we offer is shaped by and led by staff and volunteers who are from the community, many of whom are in recovery themselves, because we believe that folks closest to the issues should be the ones leading and developing solutions. In addition to our digital programs increasing access, in addition to digital programs increasing access, we're also leveraging our technology to advance connectivity across recovery resources. We're super excited about this work. It's fairly new, but we currently have a space in our app that other organizations, RCOs, and nonprofits can create mini sites, and essentially anytime someone comes into our app, both folks from Phoenix and folks from those programs can automatically see free recovery and mental health resources and plug into that. It's fairly new and we're excited. I just want to thank the city officials for helping advocate for the Phoenix mission over the years, and even many of you have participated in programs, and folks from the city as well. We received a $400,000 investment through ARPA funding in 2023, which we were incredibly grateful for. This was a unique opportunity for us to demonstrate our impact during a critical time, and we were able to reach over 4,000 individuals across the city. This is a portion of the approximately 10% of residents who are experiencing substance use, but it's also the broader community who may never report having an issue, which is often a critical missing link. Our programs support individuals in recovery, those directly impacted, family members, loved ones, frontline workers, and we prevent many more who might be at higher risk from maybe ever having to struggle. I'll wrap up my comments in 1 minute. Our model is really, it's not about what people come in and whatever kind of brings them through the door. It's more about this forward-looking approach. And it sounds really simple, but our model is informed by significant evidence, and it's yielding some compelling outcomes. Of our active members, over 83% report maintaining sobriety or recovery. And when we look at long-term outcomes within 1 to 5 years of involvement with the Phoenix, our members experience 83% reduction in unrelated mental health issues, a 95% reduction in family violence, an 82% increase in being able to pay their bills, and a 91% reduction in going to jail. If we continue to break down the barriers and the stigma that get built up around people with substance use disorder, we can transform this community approach. Partnerships are really critical to this work, and we're so proud to have collaborated with the Boston Public Health Commission, Boston EMS, Dr. Ojikutu, and Chief Hooley. Your teams are amazing and have really helped elevate our work over the years. We also partner with Boston Fire, Boston Police, and many other organizations throughout the city. And while every partnership is unique, the commonality is that folks are coming together who are impacted in some way or wanting to create this holistic approach to wellness. So as we move forward the 2025 budget, we are just wanting to show the impact of our work and urge the administration to continue to support funding that's directed towards wellness and holistic recovery and make sure that it's accessible to a wide variety of programs. The Phoenix isn't just a gym, it's really a lifeline for thousands across the city. We're grateful for the many city officials who are committed to amplifying this work and look forward to continued collaboration with you all. Thank you.
Thank you for the testimony, and thank you for all your service and all the work that you do here in the city of Boston. I now go back to my council colleagues for a second round of questions. Council President Louis Jen, the floor is yours.
Thank you so much, Chair Worrell. And I think that you were asking questions about ARPA and then just hearing Sydney's testimony from the Phoenix. I think, you know, ARPA, these one-time transformative infusion of cash really helped illuminate which programs that and ideas that deserve and are worthy of funding. And I find ourselves in like this very, as a city, difficult place where, you know, it's one-time funding with ARPA, but there are so many meritorious organizations and people doing the work that I hope that we can really, I don't know if there's analysis or data being done on sort of how, you know, ARPA was used and what we've learned from that in terms of like how we are using the budget that you have differently as a result of what you saw did and didn't work as a result of ARPA allocation. Does that make, is there any comment? Or
so I think part of my hesitation in commenting is that we're still distributing ARPA dollars, you know? Yeah. And I think we are doing some innovative work, as I mentioned, with those dollars, not just in the space of, you know, viruses and, you know, infectious diseases, and not just in mass and CAS, but in this relationship with community and community partnerships, and how do we fund them in a way that allows them to be more empowered, you know? And I think that's one of the questions that all public health departments, you know, and all city departments really struggle with sometimes, right? So how much money can you give? Can you really deeply invest in community? Can you give them money up front as opposed to being reimbursable so that they can actually do the work? So we are doing that in at least one area with our Community Health Empowerment Fund, which is ARPA dollars that we gave out to 10 different organizations, giving them 25% up front, having them join learning collaboratives, you know, having them, you know, actually build infrastructure and learn from each other as they try to address key equity issues around the city. So it's experimenting a little bit to say, is this the way that we should be doing this going forward? And I think that we will learn something from it, just given a little bit more time to really analyze that.
Thank you. Yeah, I mean, oftentimes the work is already being done that we want to happen by community leaders, oftentimes women of color who don't have access to resources and who haven't been funded. And so it's been, just in my 3 years on the council, it's been interesting to see organizations transform or really to build out their capacity as a result of getting resourced by the city. So just throwing that out there. I think a previous councilor had asked questions when it came to traffic, and it asked questions about bike lanes and their impact on traffic. And Chief Hooley, I'm not sure if you had the time to address that, but either in this hearing or another hearing when we were talking about the bike lanes and the protected bike lanes, the white flexi posts are up there are collapsible. Is that correct? And so if you know, EMS needed to use a bike lane, that's something that's available to them. And then if you could talk about, and I'm sorry if I missed this, but if you could talk about if you believe that there has been any impact, or have you seen any demonstrable impact on bike lanes on response time?
Nothing demonstrated, nothing documented. Again, like I say, whether it's dedicated bus lanes, which, you know, or bike lanes, as far as being able to drive over the flexi things, BTD's always gone on record as saying, like, do what you got to do. You know, that's okay. That's people, other vehicles are riding over them all the time, so they acknowledge that. And actually trying to be even more involved with them when they are trying to plan different either different traffic calming or patterns. I mean, over the years, we've shared data with BTD going back when before they even started with some of the bike lanes on Commonwealth Avenue, or initiatives to try to promote the use of bike helmets, or you name it. Well, we would give data about where we were seeing not just injuries related to, say, bicyclists or pedestrians, but also the acuity, where we were seeing ones who were worse off versus ones that were minor injuries, so that they could help prioritize how the city would be using that to put in either more enforcement or better traffic calming measures. We would make that available. And we still are part of the city's Vision Zero, and we still share as much of that. We even try to capture, like, if it's truck versus pedestrian or bicyclist, versus a car versus bike on bike or whatever, so that they can try to drill down, and so they can try to really prioritize where you have to put efforts. Again, are they just trying to slow traffic, or are they trying to protect pedestrians, which is, I imagine they approach it different ways, the way they do design. I'm not a street engineer by any means, but we like, to the extent that we can be involved, either providing info that helps them, but also where they are going to be doing, either making changes, whether it's changing streets, flow, traffic one way to another, because that has impact on us as well. We want to make sure we communicate, and then if we have a chance to say, like, hey, has anybody thought about blank? So we just like being a partner in it. At least we ask for that.
Thank you. Thank you, Chief Hooley. And I think that's very smart to be working in partnership with BTD, and that BTD has the foresight to reach out to you to determine whether this makes sense for our street. So thank you. My next question is for Dr. Ojikutu, and I just wanted you to outline the Black maternal health initiatives that BPHC is working on, and if you could share that with the council.
So I think that's a really important question. We certainly know that Black morbidity and mortality, there are significant inequities in what we're seeing, as well as with infant mortality. So within Healthy Start initiatives...
I'll jump in, just sorry. I think what I wanted to also say is that the former city councilor, Attorney General Andre Campbell is, again, doing a lot of grant making with organizations that are really tackling this, I think, in the model of sort of championing community that's already doing the work. So
absolutely, absolutely. And we're working alongside many of those same individuals, organizations, and funding them in many different ways. But I'll speak sort of on a broader scale and say that we prioritize and want to address this issue, given that it's such a significant and severe inequity here in Boston, statewide, and then nationally. Within our Healthy Start Systems program, which, as you know, this is a program that's been going on for more than 30 years, but it's evolved over time. It's evolved to become stronger in terms of our ability to provide direct services to both birthing individuals, so women who are pregnant, both prenatally, during birth, and then post birth up to the age of 5 of their child. So it's not just a one-time thing. We actually have a longitudinal program that I think is very important. Most of the women, most of the families enrolled in the program are Black, and they are women primarily who are covered by Mass Health, and we essentially work by connecting with providers within the community when a woman comes in, a birthing person comes in, and they are pregnant, and then we provide support at that point. I think that the support is actually quite broad. So it's not just talking about the birth, and the prenatal issues and, all the things that we would routinely think about. It's really thinking about mental health care. It's thinking about support services that one needs. We have Healthy Start in Housing that, provides, upstream sort of social determinants of health. It's thinking about parenting skills. It's thinking about, so what about the partner? If you want the partner involved, can we help the partner? So we have fathers who are enrolled in the program. We also have Father Friendly, which is an extension of that. So we reach out to fathers if the mother or if the partner wants that to be the case, and we engage them in the process. We also offer doula services, and we are expanding our work with doulas, training doulas, as well as building capacity of doulas and making the connections around all of our academic centers, because we have doulas that are at our academic centers. Oftentimes we found that they're just not connected to people who are giving birth, and some of that is about increasing awareness and increasing acceptance of doulas and understanding the evidence base for that within the birthing process and postnatally, and getting them engaged with families. And I think that intimate connection that's made has made a difference. And if you actually look at our maternal mortality data within the city of Boston, it's actually not high, if the actual numbers. And if you look over time, I was actually just looking at this last night, the numbers aren't that high. However, we know that there are higher numbers within Black women than there are in others. So it's the difference, the disparity that is concerning. So there's that program. I think one of the other things that I think is really important as we think about Black women morbidity and mortality is really raising awareness beyond the reproductive issues, realizing that this is about something that's occurring earlier in life, and really you should think about it sort of throughout the lifespan. And I think one of the things that we're trying to do now, we're actually working with the Office of Women's Advancement on this, is to establish a women's health initiative that initially is going to focus in on Black women here in Boston. I think that, again, there's so much more to this than just that period in which someone is pregnant. It really is about what happened before, what happens during, and what happens onward. So we are focused on this issue. We know that it's of critical importance to the city councilors and to those folks in leadership. And we hope to continue to engage you in discussing our priorities and where the funding will come from to do the work that we plan to do.
Thank you.
Thank you. Councilor Mejia, the floor is yours.
Thank you. Don't worry, you're not going to be here until 7. And I promise you that. So a few questions. I think it was, I'm not sure if it was this morning or today, just everything's all blending in. But I do remember you talking about fathers and the role that fathers play. And so the Family Nurturing Center, which I'm sure you are well familiar with, they oversee a coalition called Dorchester Cares Coalition. And in a lot of the work that I've done alongside them has been specifically around the fatherhood engagement piece. And I know that there are a lot of single dads who are caring for their children, and I'm curious, in terms of programming, what, if any, particular initiatives can you point to that are focusing specifically on single dads?
I don't know of anything that's focusing specifically on single fathers, to be honest with you. But what I do know is that Father Friendly is a program that is meant to re-engage fathers in the process of, engaging with their children. Right. And I do know, just anecdotally, that in the case of Father Friendly, that we've had fathers who've ended up being the caregivers, of their children. So certainly it's something that we're paying attention to. What I would say, and I think this is an important point, is that though we care for hundreds of birthing individuals, so mainly, birthing women, we don't care for enough fathers in this process. And I think that part of that is we want to build the program. We want to make the program stronger. We want to be able to reach more men and reach more partners so that we can engage them in the process. And I think that has been a bit of a challenge, quite frankly.
Right, and the reason why I named that is because There's another program that I was involved with. It's called Family Matters, and this was through the Sheriff's Department. And we worked with the Homes for Little Wanderers and a number of different organizations. And one of their main objectives were to connect fathers, particularly fathers who were incarcerated, to making sure that even though they were behind the wall, they were still very much present in their child's life. And so the reason why I bring that up is because when we're talking about public health, I'm always trying to think about the whole family unit. Even they may be here or not, they may have other, restrictions that prevent young people from being with their father. And I think that so much of this work is always concentrated on women, and I just want to name that there are a lot of men who want to be engaged in their children's life or need some additional support, so that, and I point to the Family Nurturing Center because they have a fatherhood engagement program that is amazing. So I think that if there's something that you want to learn and dig in a little bit deeper, the Family Nurturing Center would be a great ally and a partner with you around fatherhood engagement strategies, because in my time working with them, they have done an amazing job at really engaging fathers in ways that I have not seen in a lot of spaces and places. So I want to uplift them.
No, that's great. I think, I will dig into that, and I will sort out, details and hopefully share with the team. Healthy Start in Housing does now, this is just this year, I assume, include fathers who have custody. So that is a piece of the work that we do.
Yeah, because I'm always thinking about everyone in the city of Boston, and sometimes, some folks don't see themselves in the conversations. And when we're talking about men, it's often either, re-entry or like all these stereotypical spaces and places, but we're not talking about men in the fatherhood space. And I think that, we have to start speaking life into them in ways that they can see themselves uplifted in these conversations. And so I just want to name that as something for us to look into. I keep seeing you looking at me. I still have 2 minutes and 47 seconds.
I was engaged.
Okay, I just want to know for the record, I'm feeling the heat here.
I'm a father too. So
okay,
I like the conversation.
Okay, good. Oh, so it was a good looking.
Yeah, it was a good
30 seconds back from all this chitter chatter here. So going back into the kind of the whole family conversation, that I keep forgetting where we had it, but one of the things in the community health space and just public health and prevention and intervention is that I'd like to see what, if any, programming that you're doing for the whole family, because sometimes we're focusing on the young person, sometimes we're focusing on the mom, but I'm curious about family initiatives that sees the whole family as a unit. What programs within your jurisdiction are doing family-specific programming?
So Healthy Start systems and Healthy Baby, Healthy Child is about the whole family.
But it's not just the baby?
It's actually not. It really meant to incorporate the unit, the family, and so parenting skills are shared. Referrals are made as needed. I think they have a really good understanding of the fact that it's not just about the woman or the birthing person and the child. It really goes beyond that. I think Healthy Start in Housing is another program that really does think about, well, we have to house the entire family. This isn't just about a woman and her child or a father and his child. So I do think within the Child and Adolescent Family Health Bureau, we are thinking along those lines, but certainly you're right. It's something that we should pay enormous attention to, because it does have plays such a critical role in terms of health outcomes.
Yeah, no, thank you. And then the last thing with my 50 seconds left, and this is really around mental health, and I just want to thank you all. Every time we do a fair or something at the Burke, we did our second annual Health and Wellness Day, and you all were there. Your team was present, and I know that you all have currently allocated more resources around mental health, and then you have this whole campaign. I would really love to see a citywide day of care. We do this right now within the Burke, and I've been working hopefully with the district so that they can take this model and make it district-wide in all of our Boston public schools. But I do think that a day of care we can all benefit from. And I know you kind of were doing some of this during COVID, where you were having those community events, but I think being super intentional around trauma and caring for, because there's so much stigma when it comes to mental health, and I think that if you can get people into the door, there is Joseph Bennett, who does a mental health and wellness retreat for men who are coming home. He's super intentional. I think I would love to invite you to one of his men's retreats so that you can see what it looks like. But I think that more focusing around mental health spaces and places for people to be able to learn about Reiki, yoga, meditation, all that stuff that's bougie, that we should be engaging in. I think I'd love to, outside of the funding, like I'm not asking this for a budget. I'm just saying as maybe we can work with outside partners to make it happen.
100%. I think that one of the things that we're doing with our youth mental health funding is holding these Rise Up Youth Mental Health Summits. So yesterday it was one which was just for the youth, and they did a lot of discussions and activity around destigmatizing mental health and the needs that young people may have, but they may not articulate. On May 28th, there's going to be one for parents and caregivers. So for them to talk about their issues, we can make sure that you have the flyers. And then on June 3rd will be the providers. So the idea is to gather more information to inform further work. But I do think that it's also important, like you said, to have a space where people can come and they can talk and share and commune with each other. I will, absolutely.
Thank you. Councilor Coletta, the floor is yours.
Thank you, Chair. I hope you guys get a nice long break after this. You all have been talking a lot. Sorry, going back to Chief Hooley, and then I'll go to Dr. Ojikutu on the fire response and homeless families. Focusing in on East Boston. So last year alone, Logan Airport serviced 33 million people with the expansion of Terminal E, and they're anticipating well over 40 million. And so East Boston has only 2 ambulances, which are reporting to the airport and servicing the airport and taking vital resources away from the city to Massport land. So have there been discussions with Massport about steps to decrease the use of our city resources? Has Boston EMS discussed another single responder unit to evacuate the calls and determine if we need to assign an ambulance to it?
As far as to see if Logan come up with a better plan for, if it's ones coming from, well, certainly if, in rare cases, they could be, medical ones coming in where somebody's going to book something for a transfer already, but usually it's more somebody from the traveling public that's initiating the call, right? Or it happens on property over there, or one of the car rental places, or a hotel, or somewhere on Massport property, including, or at the T station, or somewhere around there. So it's a little bit hard to tell who's the flying public versus somebody who works there as well. So I don't have a good breakdown on that. As far as trying to get additional resources, I think one of the things that will also help us with backing up East Boston more on a regular basis would be when we do get, and this should be in the near term, that the two-bay facility over in the Seaport. The ability to house a second unit over there, perhaps that one would be ALS, and have trucks that would be that much, we have another quick access over to East Boston. Because what we try to do, like even now with the tunnel closures, is to, if you have 2 trucks, is the idea is what the Sumner Tunnel thing would be, as soon as you get one of them gets occupied, to try to think, well, do I have somebody I can send over there? Somebody else I can send back over there? And then hopefully that's dependent on a unit being available. You know, instead of waiting until, okay, now I have both trucks over there committed, or transporting to the Boston side because the hospitals are over here. Now I have to find somebody to head over. So the idea is being able to put more trucks into the rotation to be available for Eastie. Because, you know, similar to the airport, we get more and more calls for other facilities. Don Orione, other places, you know, Charlestown, you name it. It's happening in other parts of the city as well.
Thank you. And I think the 2-bay facility in the seaport could be of use and it could be helpful. That leave it to me to discuss with Massport's new CEO, whoever that is, in conjunction with my state colleagues to try to get more resources. But I do think that that's going to be vital in the coming years, especially if the airport is going to take away so many of these resources and pull the ambulance away from East Boston, Charlestown, and other calls.
Excuse me, I didn't mean to cut. I'm sorry.
No worries. I cut you off.
I'd be happy to get involved with that. I know that they're what do you call it, GM? What?
CEO.
Thank you. I forgot the titles, but I know that's changed a couple of times in the last few years, and some we had better communication with, but we have to make sure we get working through IGR, of course, that we get a good relationship going there. And to look at that, similar, like if we're planning present needs, 5-year needs, 10-year needs for a community, we should be looking, again, as what the airport is, what their demands are going to be, what their needs, what they're going to be looking at, how they're impacting Boston. No different than when we met with the developers when they were planning to put the casino in Suffolk Downs. We projected a few things. We said, okay, here's the deal. You're going to finance a separate ambulance. It's going to be ALS. You're going to build the thing. And I mean, it didn't come to fruition because Everett wound up getting it. But on the other hand, Massport, by providing two garages and a trailer that's okay, but perhaps they could do better as far as to help to contribute to it, what the impact is on East Boston, even going beyond the airport property, just the general, even the traffic in your streets, our streets over there, the impact on the T, because we're trying to put more people. We would say, okay, take the T, use the silver line, use the blue line. There's impact on that because of the development. No different than on the port side, on the harbor side, cruise ship side. Yeah, that's going to be more and more impact in the seaport district. So to try to get the authority, meaning Massport, perhaps come a little bit more, be more of a partner at the table to help fund some of these resources here. Yeah. And again, it's not about empire building here. It's about being able to respond to the calls, which is what we want to be able to do. Be part of their planning, part of the disaster planning. The city is starting to tackle that now to look at neighborhoods. So, but they're a significant part of the East Boston and South Boston, part of South Boston neighborhood now.
Yeah, they're going to be, their participation in the neighborhood needs analysis, the upcoming one that Chief Jameson promised us, is going to be key. So just putting that out there again so that it doesn't get lost. Thank you for that answer. And just speaking of traffic too, obviously we have the Sumner Tunnel. Oh my goodness. The Sumner Tunnel closure had a huge impact on ambulance response times. Ambulances that could go through the Sumner Tunnel and get to MGH in 5 minutes are now being diverted through the Ted Williams Tunnel and going to BMC is my understanding. How did that go? What are some of the planning, or what has the planning looked like for this year, given that we're going to be looking at another closure for a month?
Yep. Well, and again, I could pull up the summary that we did sort of at the end of last year and share that again, as far as, because we were monitoring and doing reports basically week to week, like where the patients were going and where were they coming from? Were they coming from the airport? Were they coming from, what was the address for picking them up at? Maybe we were obviously guarding patients' privacy, but we'd say, and where were they going? It was at the hospital of their choice we were tracking. The majority certainly were going to the Mass General. Some others would be going to BI. Most of the ones that were going to the BMC were, in fact, patients who did request to go there. There may be some people who had relationship with docs at East Boston Health Center and their primary was, and that's fine. Then we should have taken them there. If people were, we did not want to take people anywhere as a matter of our convenience. We really wanted to do it more to support where the patients are going, where they've established a relationship. So this was something that we always wanted to put that is a priority. Looking at the times, looking for the unit availability, looking for outliers, looking for if we had that, you know, thank goodness, rare patient where if, you know, we need the state police to like stop traffic at the portals, we can get somebody through. Because it would, with the coming into the Teddy coming back was where the bottlenecks would be, right? And being able to make it, once you got through there, you would do okay with your lights and siren, but getting into that funnel could be difficult. And there was something we did try to establish with them, that if we had a patient that was that critical, that we could call ahead and ask them for their assistance on that. The bridge operators for the, if they were opening up the other ones, they got pretty good about just on their own, even calling and notifying us of a scheduled or watercraft coming up so that we
To
could
Chelsea?
work. What's that?
The bridges to Chelsea?
Yeah,
Okay.
yeah. The city was pretty responsive, the city one, but also, but yeah, those two bridges there. And then, in some of the worst case, there would be if something happened to one of the other, not worst case, there's a lot of worst case. We'll leave those out. But one evening we had, as you were coming off the Tobin into Boston, the Central Artery North to Cana, there was some sort of an accident there that restricted that down to one lane. And they thought there was something leaking from a truck. The state police kept it going, but then that started backing up. Well, that's our alternative route out of, and that's where they try to divert a lot of the traffic in Eastie during that. You know, we brought, you know, we tried to keep an additional unit over in East Boston. We were certainly concerned about what the impact was going to be on Charlestown with that, because people then started trying to find the other ways through Chelsea. We're really trying to expedite getting that road back open and impress upon the state police. No, you have to keep that lane moving because that's our only way. And the only impact that we had there was an ambulance on the North Shore trying to come into Boston, was one of us, but that we actually called and we facilitated trying to get them through. So it's going to be on us to really, really try to always keep situational awareness, because even if we think, okay, the things seem to be moving, it can change so quick when there's a car breakdown or somebody runs out of gas in another tunnel. Those are the kind of things that can even just can impact us. So we have to make sure that their center for the state, that they keep that up. But we got a lot of assurances kind of going into it last year, but we didn't get too many chances to test it out. So we really have to try to hold DOTs and MassDOTs, I don't say feet to the fire, but yeah, I guess so, to make sure that they're going to be responsive if we do say, hey, we need help now to try to move things along. Because it's hard to anticipate those things until they happen.
Thank you. Council Fernandez Anderson, the floor is yours.
Chair, I think it's late. That's what I think. I will submit the rest of my questions to the chair. I thank you so much for your time. My questions get way too technical, and it's mostly like programmatic because of the emphasis on the services that you provide. I did want to make a comment, Dr. Jakutu. I'm very familiar with the work that you do in the different departments. I used to work for Father Friendly. I also worked for a department that, I don't know if you still do this. You guys do inspection where you check if people are selling cigarettes to minors.
Yes.
I looked so young, so, you know, even though I was in my 20s. And I used your services very, very often. I worked for Women Connected Affecting Change through DMEC, Infectious Disease Department. So I did HIV testing and counseling. So obviously connected with you guys. I also worked from 13 to 18. I worked at Boston Public Health Commission. I'm sorry. Roxbury Multi-Service Center, where with folks there, we had a rape crisis center. Boston Public Health Commission was a huge partner in training, certifications, and I also provided CPHI, like behavioral health and intensive care services through Children's Services of Roxbury and other mental health clinics. So I've had to use your programs extensively, like Healthy Baby, Healthy Child, like all of your programs. And I just think you guys do phenomenal work. I don't see these gaps in what you're doing. I think that there's an opportunity here where the equity cabinet could really, you know, grab the bull by the horn to connect with you and all the wonderful work that you're doing, all the research and the data, but also to create some sort of campaign around a movement around dismantling systemic oppressive structures. And I think it does take a level of analysis where we're reporting back on measures, you know, on progress. And I think that piece is with equity, and I'm going to look to partner with them and see the work that we can do there on the policy side, but as well, hopefully, whatever I can offer to assist. So I just wanted clarification on that, because I know there's so much that people don't know what you're doing. And to be able to run, I'm not even sure why your title is like executive director, or it's also commissioner, but it's like you have multiple jobs, and to be able to run a commission of that magnitude is just incredible. So Chief Hooley, you know my sentiments about you. I don't sit here and thank people to death, because I thank them for their work and I keep them moving to the questions, but you're one of my favorites, and I just, if I say it, I'm saying it because I really appreciate you. I think you guys are obviously guardian angels, and just thank you for everything that you're doing, and I hope you take that with my true intentions. So with that, I think I leave it to the chair, whatever comments or where he wants to take it, but it's late. I will submit additional questions on record. Thank you so much.
Thank you.
Thank you. Just want to say thank you guys for all your work. I want to thank Central staff, BPD, BPPA, the union reps that are here, my team and my council colleagues for showing up and attending and asking great questions. This hearing on docket number 0670 through 0678 is adjourned.